He in Prince Sultan Military Medical City, and our dearest colleague, Dr. Faisal Azam, medical oncologist in King Fahd Specialist Hospital, Dammam. Dr. Abu Ziada, please, the mic is yours.
Good morning, everybody. Today we have comprehensive talks about GU cancer sessions. It's my pleasure to introduce our first speaker, Dr. Muhammad Al-Ghamdi, consultant of medical oncology and head of the Department of Medical Oncology in King Saud University Comprehensive Cancer Center. He will talk today about the keynote for 2.6. Welcome, Dr. Ghamdi.
Thank you so much, Dr. Abu Ziada, for the nice introduction. And I would like to extend my thanks to the organizing committee for inviting me. So I have been asked to talk about the recent updates, the 42 months update of the combination of pembrolizumab and axitinib versus sunitinib in the first line therapy for advanced renal cell carcinoma. There has been a huge advances in the treatment of the clear cell renal cell carcinoma over the past few years. I remember when in 2006, when we started to have the only the TKI, the Sutent, and then since 2014 or 15, we now have so many options for treating such patients, including the combination of immunotherapy or combination of immunotherapy and tyrosine kinase inhibitor. So today I'm going to talk about the pembrolizumab, which is an anti-PD-1 inhibitors, and axitinib, which is the second generation selective VEGF-1/2/3 tyrosine kinase inhibitor. So this was presented in the last ASCO. I must say that this study was presented 3 times. First, the initial analysis was presented in the 2019 ASCO, then updated the 24 months updated again in 2020, and this is the 42 months update presented this year. So starting with some introduction. So we know that in the first interim analysis of the keynote 426, the combo pembro and axitinib demonstrated significant improvement versus Sutent monotherapy in the patients so presented with a clear cell metastatic RCC. And for the extended follow-up of a median 30 months, it did continue to have a superior outcome of the combo versus Sutent. And today I'm going to present to you what was presented in the ASCO 21, which is the median follow-up of 42 months. So, and the minimum follow-up for this was 35.6 months. This is the study design. So these are the patients with a newly diagnosed or recurrent metastatic stage 4 clear cell RCC with no previous systemic treatment for the advanced disease with a measurable disease. And the stratifications was based on the International Metastatic RCC database, which basically looking at 6 factors: the performance status, the time from diagnosis to initiate the systemic treatment, the hemoglobin level, calcium, platelet, and neutrophils. Randomization was 1-to-1 with the pembrolizumab with the axitinib. Pembro was given up to 35 cycles or approximately 2 years versus Sutent, the standard of care at that time. The dual primary endpoint was the overall survival with progression-free survival, and there was also another secondary endpoints like duration of response and overall response rate. So this is the disposition of study treatment. So 861 patients randomized. The pembrolizumab, the study treatment status, when it was presented, about 14.5% of patients still ongoing, while the majority had a discontinuation of the treatment. Sutent, 9.4 ongoing and 90.6% discontinued. These are the baseline characteristics. It was well balanced between the 2 groups. Majority of patients were men, accounting for 2/3 of patients. Majority of patients also had the intermediate or poor risk. There were about 18% with sarcomatoid features, which is usually have a poor prognosis. And also majority of patients had a previous nephrectomy, more than 80%. This is the subsequent anti-cancer therapy, and as you can see, more patients on the sunitinib arm received a subsequent therapy, 73%, while the pembro and exitinib, 58%. And majority of the sunitinib arm, they received either anti-PD-1 or PD-L1 inhibitors, and about 74%. And the opposite for the VEGF or VEGFR inhibitors with the pembro and exitinib, accounting for 88%. This is the overall survival. And as you can see at the 24 months mark, it was the end of pembrolizumab treatment. And the updated results showing that pembro and exitinib resulted in an overall survival of 45.7 months versus 40.1, which led to a hazard ratio of 0.73. This is also the progression-free survival in whole population. Again, hazard ratio of 0.68. That's resulted to a 15.7 months with the combo versus 11.1 months with the sunitinib. This is just to show you the objective response rate. More patients had a documented response with the combination up to 60.4% versus only 40% with the sunitinib. For the complete response, up to 10% of patients had this with the combination versus 3.5%. And this is just to show you the duration of response, and it was higher with the combination pembro and exitinib across all the timelines, 6 months, 12 months, 18, and even 30 months. Looking at the subgroup of the favorable or intermediate poor risk, if we look at the overall survival, this is the 42 months rate. With the favorable group, there was no difference between the two. It was 72 versus 73%, which led to a hazard ratio of 1.17. While looking at the intermediate and poor risk, we can see a more response and a more favorable to the combination of pembro and exitinib. Progression-free survival, there was a benefit across all the favorable and intermediate and poor risk, favoring the combination treatment, as well as the overall response rate, again, favoring the combination treatment. These are the treatment side effects. About more than 20% of patients had a side effect of any grade. Mainly it was diarrhea with the combination as well as with the sunitinib, and we can see more of hypertension. That's probably related to the exitinib. Looking at the immunotherapy side effects, it was more and seen more, especially grade 3 and 5 with the combination. It was 13.5% versus only 2.4%. And the commonest side effects was the hypothyroidism and hyperthyroidism with the immunotherapy. So to summarize, so this is the median follow-up of 42 months of the Keynote 426. It represents the longest follow-up of a checkpoint inhibitor combined with the VEGF and VEGFR, because we got also the 40 plus months follow-up of the combination of nivolumab and ipilimumab, and it was also positive for the intermediate and poor risk. The combination continued to demonstrate clinically significant improved efficacy when it compared to sunitinib for those who did not receive any treatment previously for advanced clear cell. The overall survival hazard ratio of 0.73. The progression-free survival hazard ratio of 0.68. The overall response rate was higher with the combination 60.4 versus 39%. And the complete response was higher with the combination 10 versus 3.5. The safety profile was comparable between the two arms with no new safety signals emerged. However, we could see now more of the immunotherapy-related side effects seen with the longer follow-up. And the conclusion of the presenter and the author that long-term results of the Keynote 426 did continue to support the usage of pembrolizumab, etc., as the standard of care for patients with previously untreated advanced clear cell. Thank you.
Thank you, Dr. Ghamdi, for a nice presentation. We'll move for the second speaker.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Mohammed, finishing on time. So our next speaker is Dr. Fahad bin Shamsa. He's my colleague, friend, and brother. He's a chairman of the Medical Oncology at King Fahad Specialist Hospital in Dammam. He has an expertise in hepatobiliary, pancreatic cancer, GI, GU, and CUPS. So he is going to present today pembrolizumab versus placebo in post-nephrectomy adjuvant therapy, phase 3 study, Keynote 564 study. I've heard he's quite in favor of giving adjuvant treatment in renal cell carcinoma. So let's hear from Dr. Fahad bin Shamsa.
Assalamu alaikum wa rahmatullahi wa barakatuh. Faisal, do you hear me and you see my slides?
Yes, we can.
Thank you very much. So thank you, Faisal, for the nice introduction, and thanks to Isam and Mirbat for the kind invitation. It's always a great pleasure to participate in this great meeting. So in 10 minutes, I'll talk to you about the Keynote 564 first interim analysis that was presented in the last ASCO 2021. And we will conclude after the study and we'll discuss how can we benefit from this study for our patients in the adjuvant setting. So, you know, the history of adjuvant treatment for RCC was with some controversial, conflicting results from some studies, mainly in the TKI era, and it's never been a standard of care to give adjuvant treatment for patients after nephrectomy. And we know that we expect recurrence in about 50% of patients after surgery. The main high-risk features for recurrence were high T stage nodal involvement, high grade, and M1 disease even after zero disease after resection. So the current study is evaluating adjuvant pembrolizumab versus placebo for patients with clear cell RCC after nephrectomy. This is the study design. It's a randomized, double-blind, phase 3 study. They presented the study at the cutoff date of December 2020. The median follow-up was just more than 2 years. So the patient in this study are clear cell RCC after nephrectomy, randomized within 3 months after nephrectomy. They received no previous systemic treatment, good performance status, and they had to have a sample for PD-L1 evaluation. They recruited just less than 1,000 patients, 994 patients, stratified according to their risk factors. So they would receive either pembrolizumab 200 milligram every 3 weeks or placebo. The primary endpoint was disease-free survival. Overall survival was secondary endpoint. So the study is very well designed and very well balanced for the main features or characteristics of patients. They divided patients either intermediate high or high risk patients for the M0. So for the M0 intermediate high, where the risk factor was either grade 4 or sarcomatoid or T3. The high risk patients were patients with T4 tumor or nodal involvement. and also, of course, the M1 disease. All of these are very well balanced. In this study, interestingly, patients were of CPS score of 1 or more. This is the primary endpoint, disease-free survival, and for the first time, we have a clean and a clear positive study regarding its primary endpoint in RCC. So the 12 months rate for disease-free survival were 85% compared to 76% for placebo. At 2 years, 77 versus 68%. So that was statistically significant with a hazard ratio for disease-free survival 0.68. So very clear positive study. Regarding subgroup analysis in the intention to treat population, it seems that everybody would derive some benefit from adjuvant pembrolizumab. But it's obvious that patients with high CPS score derive a clear more benefit from patients with CPS less than 1. The rest of the subgroups, all of them, they derive a clear benefit. So this is the overall survival, and I remind you, this is the first interim analysis only at 2 years in a disease like RCC, early disease, in the adjuvant setting. So you don't expect really to have number of events that qualifies the study to tell an overall survival benefit. Although from the curves you see that maybe some trend towards benefit from pembrolizumab, but only time will tell. Regarding safety, there was no surprises with pembrolizumab. Now we are very well familiar with pembro and other immune checkpoint inhibitors. The most common grade 3/4 adverse event were fatigue, diarrhea, and rash. But there was no treatment-related deaths in the study. I remind you, the patients, they will receive pembrolizumab for up to 1 year in the adjuvant setting. Also, immune-mediated adverse event. So these patients, only 7% of them require high-dose steroids. And the grade 3/4 immune-mediated adverse event were quite uncommon, less than 2% incidence of any grade. So this is the conclusion of authors, and I have my own conclusion, maybe to discuss with Faisal. So the authors concluded that in the first pre-specified interim analysis of this phase 3 keynote trial, adjuvant pembro achieved statistically significant and clinically meaningful disease-free survival improvement in these patients with RCC post-nephrectomy. The hazard ratio for disease-free survival was 0.68, and the benefit was seen across subgroups in the study. The overall survival data, of course, are immature, and safety profile was consistent with previous report. It was uncommon to need high-dose corticosteroid treatment. So the authors concluded that pembrolizumab may be considered a possible new standard of care for patients with RCC in the adjuvant setting. Now, I want to discuss with you a few points, maybe in 2 minutes. So I want to remind you that most patients enrolled had intermediate and high-risk disease. So this did not include every patient. And the study, of course, met its primary endpoint for disease-free survival with a good hazard ratio of 0.68, and the benefit was consistent across subgroups. Overall, patients with higher PD-L1 CPS 1 or more tended to do better than those with our CPS score of less than 1. And the overall survival data are not mature yet. And this reminds us that almost all study participants are surviving after treatment for kidney cancer, and this includes the placebo patients. So more than half of these patients did not recur at 2 years in the placebo. So some cases never recur. So there's a risk and burden of over-treatment. This does exist. And we know in the metastatic setting now we have very effective treatments with immune checkpoint inhibitor combination. So we need to see overall survival benefit because theoretically, because the treatments now available for metastatic disease are so effective, maybe this would not, should we treat them early or should we treat them only when they recur without compromising survival? So if adjuvant pembro only delays recurrence but does not cure patients, it's unlikely to see overall survival benefit. But as I said before, only time and more follow-up of this good study will tell. So we're looking forward for the long-term follow-up for survival benefit to better understand if there's an overall survival benefit for adjuvant pembrolizumab versus waiting to treat these patients if they develop metastatic disease later. So also, we should consider the potential risk of chronic toxicity. Reading through this study, there was 2% incidence of pneumonitis, and we know pneumonitis can be chronic and can impact quality of life. Again, looking at this study, because it's included intermediate risk patients, so with the balance of efficacy and safety in mind, maybe it's worth pursuing adjuvant pembrolizumab study on only high-risk group of patients rather than having the intermediate in the pool of patients. So I think the data of this study are exciting and to be in mind. So if anywhere and any situation that we are to give adjuvant treatment for RCC, and I gave adjuvant treatment before in a special situation, of course. It's not a standard of care. So it's very exciting data, but I don't think it's yet a standard of care. Thank you very much.
Thank you, Dr. Fahad bin Shamsa. Now we'll move to the third speaker, Dr. Imad Tashkent, is an attending consultant, King Abdullah Medical City in Mecca Mukarrama. He will drive us in the phase 3 trial with 2-2 factorial design of abiraterone, acetate plus prednisone. Dr. Imad.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. والصلاة والسلام على أشرف الأنبياء والمرسلين. Special thanks to our colleague from Military Hospital in Riyadh, because we are living now an exciting day or period with the national holiday. So they brought us all together to celebrate this event among the medical oncologists. Special thanks to also Dr. Mirvet for inviting me, and I extend that also to the whole team in Riyadh. In particular, my best friend, Dr. Asam Murshid. Can you see my slides? No? Can you see now?
Yes. Oh, go ahead.
Okay. So, prostate cancer is among the interesting area to treat. And I'm sure all of you noticed that since we have significant advances in the past years. And in last ASCO 2021, Karim Fizazi also did with his colleagues the phase 3 trial with 2x2 factorial design of adding abiraterone with or without radiotherapy in men with de novo metastatic castrate-resistant prostate cancer. So the first result was presented, and also it's very interesting to see that this result has been extended and presented in last week in ESMO 2021. So when little bit about the background, and when the accrual of PIS1 started in 2013, ADT was alone the standard of care. And then in 2015, you can see that docetaxel was shown to improve survival. And in 2017, when the Latitude and Stampede trials demonstrated the efficacy of abiraterone to improve survival. And this benefit was subsequently confirmed in 2019 with the addition of androgen receptor pathway inhibitors, such as apalutamide and enzalutamide. And finally, the radiotherapy of prostate cancer was shown to improve also survival, especially in oligometastatic disease. Very nice about this program. It is actually to facilitate academic randomized trials in men with prostate cancer. And this is very flexible structure, and each trial is independent. Candidate for PIS1 were men with de novo metastatic prostate cancer, and also good performance status. And they were received up to 3 months of androgen deprivation therapy before randomization. And stratification was based on performance status, metastatic sites, type of castration, and docetaxel. Docetaxel have been used in many trials in the past few years since the advancement of clinical trials and management of prostate cancer. So if you look at treatment and if you see the presentation for the first time, you will feel a little bit confused in the beginning, and I'll try my best to make it very simple. So standard treatment included ADT used continuously. In the beginning, was docetaxel was optional. And then because of the results of Latitude and Stampede, docetaxel was recommended. The experimental treatment included the usual dose of abiraterone, 1 gram with prednisone until disease progression or intolerance to concomitant docetaxel. Radiotherapy of prostate was given in this dose. So to make this slide even simple, I would say here the standard treatment is doublet and the experimental treatment is triplet. So doublet means ADT plus docetaxel. Triplet means abiraterone and ADT and docetaxel. So you can see also because of the evolvement in standard of care, docetaxel came and have been used as mandatory in this trial over time. The primary endpoint of PIS, they had 2 co-primary endpoints, the RPFS, the radiographic progression-free survival, and was defined according to PCWG2 criteria, and imaging was requested at least every 6 months after development of castrate resistance. Looking at patient characteristics, the trial population reported by abiraterone randomization, there was no meaningful differences between arms was observed. However, I would like to highlight one point here is the about 2/3 of patients, approximately 60%, they were high volume disease. Looking at the analysis of the co-primary endpoint, the RPFS in the ADT plus docetaxel population, the abiraterone reduced the risk of radiographic progression-free survival or death by half, with a median of 4.5 years compared to 2 years in the control arm, leading to a significant difference of 2.5 years in median, favoring the triplet systemic treatment. Looking at the subgroup analysis, importantly, all tested subgroups pretty much seem to benefit from the addition of abiraterone. Also, the RPFS showed improvement in both high and volume disease, and this slide was added based on last week, the ESMO Congress. You can see 4.1 year compared to 1.6 in the high volume disease with statistically significant number. When we compared that to low volume, again, it was statistically significant, but the control arm was 2.7 and the standard of care, which is the triplet, is not yet reached. So we need some time, although it was statistically significant. Interestingly, the first analysis in ASCO, we did not have the data for OS. It was not yet ready. And now in the ESMO Congress, it showed 5.7 years compared to 4.7 with a hazard ratio of 0.82 and statistically significant. Also, when we talk about this in the ADT plus docetaxel and plus or minus radiation therapy, you can see the control has 4.4 years, but the standard of care and abiraterone not yet reached, with still statistically significant value. When we talk about overall survival in high volume and low volume disease, you can see significantly and clinically meaningful improvement. You can see the 5.1 versus 3.5 years. And again, the hazard ratio and p-value was significant. But when we look at the low volume patients, we still need maturation of these data. Looking at what happens in those patients because they are receiving triplet therapy, you can see that those patients, they do have received further lines, and you can see most of those patients receive chemotherapy like cabazitaxel and then enzalutamide. They reported the grade 3 and 5 toxicity. When you look at both arms, you can see more or less same numbers with still some slight increase in hypertension. However, I was looking even for the data of all grades, and we know docetaxel alone or abiraterone alone is not a nice drug for patients. They do have a side effect, but what they reported is only grade 3 and grade 5 toxicity. So in conclusion, the author conclusion in 2016, the adding abiraterone to docetaxel improved RPFS by 2 years in de novo metastatic prostate cancer, and overall survival also improved with 25% reduction in risk of death, even when 84% of metastatic CRPC in men in the control group receive at least one life-prolonging treatment. The benefit translated to a median of more than 1.5 year, especially in high volume metastases. But for the low volume disease, we still need more data. So toxicity was expected with no apparent synergistic side effects from this combination. Karim also highlighted one last slide where he demonstrated the nice great work was done over years, and you can see ADT alone, we're talking about 30 months. With addition of docetaxel, we're talking about 40 to 50 months. With abiraterone, exceeding 50 months, but with the triplet therapy, we're reaching 61 months. So with that, I conclude, and thank you.
Thank you, Dr. Ahmed, for nice presentation. Next speaker is Dr. Abdulrahim Ashamkiti. He's a medical consultant of medical oncology in Comprehensive Cancer Center in King Fahd Specialized Hospital in Dammam. He will talk about the phase 3 study for lutetium in patients with metastatic castration-resistant prostate CA. Go ahead, Dr. Abdulrahim, and the floor is yours.
Thank you for the introduction. Guys, do you hear me and see my slides? Guys, do you hear me?
Yes, yes, Abdurrahim, you can see. And
okay. Yeah, just to make sure, thank you for the scientific committee for inviting me today. Thank you, Dr. Abdulaziz Hamad, Mirvat Mahrouz, and Dr. Hassan Marshid. It's an honor to be among great panelists today and great speakers. And I enjoyed the first part, and I wish to take you in the next 10 minutes in another presentation about the prostate cancer. And my talk will be about the new kid in the block, lutetium-177, PSMA-617, the last trial vision that was presented by Dr. Morris. My disclosures. And as you know, guys, just one second. PSMA is a membrane-bound enzyme that is highly expressed in prostate cancer through different stages. It's restricted in normal tissue, which makes good an excellent target for both PET imaging and radiotherapy. PSMA-617 is a small molecule that can target PSMA with high affinity and can deliver lutetium-17 via receptor-mediated endocytosis. For this trial, eligible patients had already been treated with at least one androgen receptors pathway inhibitors and 1 to 2 taxane regimen. The only patient for whom chemotherapy was felt to be inappropriate were eligible, and they planned to be a non-chemotherapy standard of care. Physician can use anything except immunotherapy, chemotherapy, radium-223 therapy with investigation drug, and the reason that they don't know the safety about the combination. They include people with good functional status, with life expectancy more than 6 months. And there's one more criteria that they wanted PSMA positive people with at least one PSMA positive lesion with uptake higher than the liver by definition, and to have no PSMA negative metastatic lesion, no lymph node more than 2.5, and no lesion in the solid organs. Scheme of the trial, they randomized people to protocol standard of care and lutetium PSMA in one arm and standard of care in the other arm, 2 to 1, with the plan that they stratified the patient based on functional status, LDH, and liver metastasis, and they followed them up with every 8 weeks scans during treatment and every 12 weeks follow-up. And the scan were reviewed by blinded central review. And they gave them the options to continue more than 4 cycles if they have good response. They had 2 primary endpoints, radiographic progression-free survival as per the prostate cancer work group Force 3 and overall survival. To have any one of these endpoint positive, that will make a trial success. They have a different secondary endpoint, including RECIST overall response rate and skeletal time to first symptomatic skeletal event and safety as well. They screened 1,179 patients. 12.6 were PSMA criteria were not met in those patients, and 86.6 were met. So they randomized 831 patients to the trial. At the beginning in June 2018, they randomized, at the early randomization, they noticed a lot of dropout even before starting the treatment. So after discussing the FDA, they educated the nuclear and they, and I mean the investigational physician as well, and the dropout was improved significantly. And for this trial to avoid any bias, they did the radiographic PFS only for people after the second randomization and overall survival for the whole group. If you look at the characteristics for those patients were well balanced across treatment arms with good functional status, mainly 0, 1 up to 2 with lung, liver, and lymph node metastatic disease. They did as well balance patient based on the previous cancer treatment. As you remember, all of them, they had androgen receptor pathway inhibitors and 1 to 2 taxane regimen. Looking at the primary endpoint, they found that lutetium-177, PSMA-617 prolonged overall survival and decreased the death by 38%. The median overall survival was 15.3 versus 11.3 months, with p-value less than 0.001. Looking at the OS in the radiographical PFS analysis, they found as well the hazard ratio still the same with 0.63 and median 14.6 versus 10.4 months. Moving at the benefit across pre-specified stratification subgroups, they found almost all groups benefited from the treatment. The only exclusion was the people with very small patient with wide line, as you see here. Moving at the improved radiographical PFS, you see the hazard ratio was 0.4 with median 8.7 versus 3.4 months. So there is a 60% reduction with lutetium-177, PSMA-617. For the completion, they looked at the improved radiographical PFS and overall analysis group, and they found the hazard ratio 0.43 with median 8.8 months versus 3.6 months. So the radiographical PFS was generally consistent across all stratification factor subgroups. The same thing for the small subgroups, it was wild, but for the most other subgroups, there was a clear benefit with lutetium-177. Moving to the RECIST response rate, they found it favored the lutetium group to look with a complete response in 9.2 versus 0 in the standard arm, partial response 41.8 versus 3.1, and PSA response was seen in 46%. They had more than 50% confirmed decrease in the PSA response. Few of them, they got more than that, like 80% decrease was observed in 33% of the group. Looking at the standard of care group, only 7% they have decreased more than 50%, and 2% had more than 80%. The other question was the lutetium and standard of care. They looked at if they continued longer on therapy, and one more time, you know, all patients, they got taxane group, and they found being on lutetium-177 give you more chance to be more on the standard of care therapy, with 7.5 versus 2 in the standard of care arm. 50% of patients had more than 4 cycles of lutetium-617. And one other thing that they found, that they looked at the rate of receiving chemotherapy after lutetium-117, and they found that slightly higher rate of people on the standard of care, they got chemotherapy, and that gives you an idea that overall survival was not because any post, like chemotherapy given after lutetium PSMA-617. Side effects, moving on to safety. They found that 85% of patients, they got a form of side effect. With 28%, they got grade 3 to 5. They had 5 deaths with thought secondary to lutetium-177. And for the side effect, the usual, they had like quarter or half of the patient, they got any form of bone marrow suppression, leukopenia, lymphoma, anemia, and as well, dry mouth was noticed in 40%. 40% in the experimental arm. And other thing is renal effect that was observed as well. So Dr. Morris and his group, they concluded that adding lutetium-177, PSMA-617 to a safety to the standard of care is safe, with with androgen, adding lutetium PSMA 617 to safely combinable standard of care in patients with metastatic CRPC, extended overall survival, delayed radiographic disease progression. They concluded that lutetium PSMA was well tolerated, and these findings warrant the adoption of lutetium PSMA 617, maybe as a new treatment option in patients with metastatic CRPC. There was some question about the discussion, about the resistance, about the response, about the way that we deliver the treatment, and the question about the resistance for this treatment. I think this is one move toward more treatment in the prostate cancer. I think we're lucky that we have now the PARP, lutetium, and we had the androgen deprivation therapy, and hopefully in the future we will have more information about this trial. By this slide, I want to say thank you for listening, and I wish that you learned a little from my presentation, and we will wait for any question at the end of this session. Back to you, Dr. Faisal.
So it is introduce our international speaker, Dr. Mark Duthill. He's a consultant medical oncologist in Oxford, Nuffield Hospital and Maggie's Cancer Center. I think he joined Oxford much later than I left Oxford. He has done a basic training from London, and then his research work is known in breast cancer and urological cancer. I think he's, if I'm not right, I've read about somewhere that you are an ambassador, clinical ambassador for UCare, some research charity work. So I will let him talk about the abstract discussion and adjuvant therapy in urothelial cancer. Mark.
Brilliant. Thank you very much for the very kind introduction. Sorry, I'm just going to get control of my slides. My apologies. Can you see my slides?
Yes, we can see.
Yes.
Perfect. Okay. My apologies for flashing through them. I hope I've not made the audience feel too unwell all the way from England. So look, first of all, thank you very much for asking me to present a discussion on these abstracts. So I'm a medical oncologist with an interest in both urological and breast cancer, and it's a great pleasure to talk about these abstracts. To put them into context, it's very unusual that we see so many abstracts presented within such a short time, which are really a practice changing. So the first abstract we're going to discuss, which was first presented by Brian Reaney, who's a really very accomplished kidney cancer researcher, is an update on the Keynote 426 study, which we've discussed already. Tom Powles is one of the authors on the study as well, is based in the UK. So what are we talking about here? Well, we're talking about sort of, if I put it rightly, sort of an old faithful treatment, sunitinib, which first came into our kind of consciousness in the mid sort of 2000s with clear data showing that sunitinib was a highly effective treatment, and really for many years sunitinib, the dose of 50 milligrams once a day, 4 weeks on, 2 weeks off, has been our standard of care. And it's only quite recently that we've had some new options. In the Keynote 426 study, what did they test? Well, they tested axitinib, a then standard second line or third line treatment, and combined that with pembrolizumab given every 3 weeks or so. Now, when we're thinking about the study, it's important to put it into context, and what we're thinking about is who went into the study. Well, we had all risk groups of patients with kidney cancer. So for those of you who aren't aware, favorable risk groups of patients are people who've got disease which will run with a natural course that goes into years. And when I mean years, I'm talking potentially up to 10 to 20 years with metastatic disease. Intermediate patients will have a disease course which runs between about 2 to 3 years, depending on how things go. And poor risk patients will unfortunately succumb to their disease without effective treatment, usually within a matter of months. I think going straight into the treatments, one of the things we can have a little look at is about long-term benefit. And one of the key things from my takeaway from this is, you know, when you look out at this 42-month point, what proportions of patients are ongoing with the treatment, and it's actually 14.5 in the pembrolizumab and axitinib versus 9.4. So there's a bit of a benefit. Only a small numbers of people will stay on their initial treatment. And what does that say to us? Well, it says to us this is a first treatment for patients, but it's not their only treatment. So I think that's something to be aware that this new treatment, the pembrolizumab and axitinib, is a first treatment, but it's definitely not patients' only treatment. So when we're thinking about starting patients on treatment, we just need to be aware that this is an effective treatment, but it is quite likely that the patients will be discontinued and the patients will need to have another treatment later. Now, when we're in the clinic, one of the things we want to do is we want to make our patients better. And one of the key things about these treatments is they do induce high response rates. And if you look at the combination of axitinib versus pembrolizumab, you can clearly see the response rate here is much higher at around about 60% in the intention to treat patients. And it is also very high in the favorable and intermediate and poor risk patients. And interestingly, the complete response rate is actually pretty reasonable as well, and much higher than we perhaps were thinking about when we first saw the analysis. In terms of the duration of response, again, it's long with this therapy. In the keynote study, you can see that the overall duration of response for Sutent is 11 months, but it is clearly significantly improved with a combination to around about 16 months. And these high response rates and these overall response rate, the overall response rates are seen across subgroups. What does this mean? Well, the great news is that if you give patients pembrolizumab and axitinib versus giving them Sutent, you'll see a better response in the clinic, and we've all now got experience of this, and the patients will get better. And that's ultimately what we want to see, and that does lead to a modest improvement in overall survival. Here we can see the progression-free survival advantage here. And again, it's important to note that this is sustained and it's actually seen throughout the follow-up of the study. It's important to note when we're looking at the long-term follow-up for this study that you can see that the patient numbers at the bottom start to get quite small. So this isn't a huge study. This is a moderately sized study, which is and this has shown a significant benefit because of the effectiveness of the medicines. But as we go out, the curves become much, much more unreliable, but there is definitely a clear difference between the patient populations. In clinical practice, this is quite significant. You're pretty much doubling the time that somebody will get good control with their initial treatment. And I think that's very meaningful for patients. Now, what about overall survival? What we can clearly see here is that overall survival separates, and it separates early on. And this is really, really important. I think it's perhaps our hardest endpoint when we're thinking in the clinic. And essentially, if you start somebody on this treatment, and the key thing for me is here, is this bit right at the beginning here. In other words, how quickly does the patient stop, how quickly does the treatment stop patients from unfortunately dying from their disease? And what you can see here is that immediately there's a benefit, and that benefit's sustained. One of the things we can have a look at is what's going on at 24 months and 2 years, and you can clearly see there are more patients alive at 24 months who've received this combination than just received Sutent treatment. Now, whenever we think about these treatments, we don't think about them in isolation, and that's one of the difficult things about clinical medicine. In kidney cancer, we had a choice really for many years, which was sunitinib treatment or pazopanib. These were oral TKI treatments, and these were joined for a time by cabozantinib and tivozanib, which is still approved. Now, this is some data from the Javelin 101 study, and this is from a similar treatment, which is axitinib plus avelumab versus sunitinib. And what you can see here is there's a similar improvement in progression-free survival in the Javelin study, the 8 versus 13 months. It's important to note whenever you're doing any kind of cross-trial comparison is obviously you're not really doing a direct comparison because the patient populations were different. And you can see here in the Javelin study, the progression-free survival with a Sutent was only 8 months, where it was 11 months in the previous study. But you can see here a similar progression-free survival advantage with avelumab versus axitinib. And again, in the Javelin study, they saw a similar overall survival advantage, but their data aren't as mature here. And so it's important to note that you can see here is that the majority of the patients here at this 24 months haven't reached any kind of outcome yet. Now, what about some other studies? So this is nivolumab alone, nivolumab plus cabozantinib versus Sutent in the similar population. And again, here you can see a very striking progression-free survival advantage. Dare I say, although this is not a direct comparison, it does look, the curves look slightly further apart in this study. And again, you can clearly see the overall survival again is better as well. What does this mean? Well, it means that combinations of a TKI, so a tyrosine kinase inhibitor and an immune checkpoint inhibitor targeting PD-L1 or the PD-L1-PD-1 axis, they clearly improve outcomes in terms of progression-free survival and overall survival. Which one of these combination treatments is best? Well, we haven't done a head-to-head comparison. I would argue that given that cabozantinib is a better treatment, a better tyrosine kinase inhibitor, it is probably, I think, if there was going to be a head-to-head comparison, would do the best in the first-line setting, but at best would only the outcomes would only be moderately better. So essentially, with all things being equal, if you had a choice between all of these three agents, they're all really, really good treatment options. Which one would you choose? Well, I think ultimately it's going to come down to, first of all, tolerability. And we know that some patients will tolerate axitinib more versus cabozantinib, but it's going to come down to tolerability and experience and what you're used to giving. Now, the final slide in discussing this abstract is also the checkmate data, the checkmate 214 data, which is compared Sutent versus ipilimumab and nivolumab. And again, what you can see here is a very, very, very striking improvement in outcomes. And that importantly, what you can see here on the curve, and though the curve is slightly unreliable towards you've got the tail end, we're starting to see a tailing off of the curve here. Now, what does that mean? Well, it means that these patients here who've been helped, they've been helped by their own immune system stimulated by ipilimumab and nivolumab. And actually, I do think this treatment is really something which definitely deserves a serious consideration in every patient. And the reason for that is if you get a good response in ipi-nivo and you tolerate the checkpoint inhibitor well, it's an exceptionally good treatment. And we've certainly now got patients going into years on this therapy who are doing extremely well on no treatments. Now, when we're thinking about the keynote abstract in context, so it fits within the context of a sort of an embarrassment of highly effective treatment options for kidney cancer. I think all of the treatments we've discussed are very, very good. And I think it'd be good to discuss with the panel their thoughts on which one to use in our patients. Now, the next abstract I'm going to discuss is the adjuvant data for pembrolizumab after a nephrectomy for early kidney cancer. This abstract was first presented by Tony Shweri at ASCO this year. So this is a standalone abstract in that previously, as was previously been discussed, there's been no data which have shown that adjuvant treatment improves outcome after a nephrectomy. Now, when we're thinking about the study, we need to put it into context. So who went into it? So patients with clear cell kidney cancer. And I think that's important to note that, although that makes up around 8 out of 10 patients with kidney cancer, there are a subgroup which haven't been included here, but this makes up the commonest time. Nephrectomy previously 12 weeks ago, that's perfectly standard of care. Patients are fit and they had to have their samples sent off for PD-L1. And they also allowed patients who'd had a previous metastastectomy as well in there. So what was the adjuvant treatment? Well, it was pembrolizumab given for a year. In terms of adjuvant treatments, durations, historically for chemotherapy, you might have had 6 months treatment. For immunotherapy, around about a year is standard. And that's a sort of similar standard for patients with breast cancer for some forms of immunotherapy as well. And I also believe for melanoma. And it was a placebo-controlled trial, so everybody knew, nobody knew what the patients were having. So what were the results? And I think it's important to stress, as was discussed, that these are fairly immature results by the sort of natural time course of kidney cancer. What was important is the disease-free survival was significantly improved at 77 months, at 24 months, with 77 versus 68%. So around about a 10% improvement in disease-free survival. And this was statistically significant. What does this mean? Well, in practice, if we treat 10 people with this treatment, we're going to prevent one of them from getting secondary kidney cancer. That's at this initial point. Now, one of the key questions about this is this meaningful or not? Well, if you improve somebody's overall survival, then yes, it is. And although this overall survival is only modestly improved, it is still present there. And this means that we will be saving lives by using this treatment. It is important to note this analysis, though, is immature, because these patients who are relapsing, having had adjuvant pembrolizumab, they're not relapsing into a world with no systemic treatment. They're relapsing into a world with effective, highly systemic treatment, including combination immunotherapy and TKI therapy. So any kind of effect on overall survival is going to be diluted by effective similar treatment given later on. And that's going to be important to capture what happens later on in this study, because we want to know who got what later, just to give an indication. This isn't, by the way, an exclusive problem to kidney cancer. It's all the same sort of problems are seen in adjuvant studies in melanoma. Now, when we're thinking about who should get these treatments, we always look at subgroup analysis. I think you can broadly see that all the subgroups favor the pembrolizumab arm, particularly if you've had a metastatectomy. There's a slight benefit for patients who've got a higher checkpoint inhibitor score, PD-L1, and I suspect that's going to be the group that we mostly use it in. But I must stress, this is hypothesis generating. We don't have, this isn't a huge analysis here. And I think overall, the results favor giving the treatment. What about side effects? Well, these were very, very similar to the side effects that we have come to expect from pembrolizumab. I think one of the things to be aware of is that as was highlighted, the incidence of pneumonitis. This can potentially be a very, very serious side effect, and it can be fatal in a small number of patients. Now, in the metastatic setting, I think all of us would agree that we're willing to take some slightly greater risks, given that the patients will definitely succumb to their metastatic disease. But it is going to be a concern if we see this more clinically, because ultimately, if somebody gets pneumonitis and gets very, very unwell, who would have been cured, that's a bigger problem for us in the clinic. Nevertheless, there are no new unexpected safety signals. Now, of course, this is a great advance. We haven't got any other effective adjuvant treatments for kidney cancer, and all of us who treat kidney cancer welcome this advance into the clinic. When we've talked about, this study, importantly, the thing to remember is that the Rampart study is also ongoing, which is testing adjuvant durvalumab and tremelimumab, and we're recruiting to that in Oxford, and that's testing a single agent anti-PD-1 plus a combination with anti-CTLA-4. And there's also another nivolumab ipilimumab combination study as well. So in other words, I think this is a very, very welcome study. I think it is now a standard of care. It's not going to be a treatment for all patients, and I think we're going to end up selecting the slightly higher risk patients to go into this. But it's important to note that there are other studies which are ongoing, and I expect this standard of care to improve with time. I'm going to move on now to talk about the PEACE study, which was first presented by Karim Fazazi at ASCO this year. And then often what happens with these clinical trials is we don't hear anything for some time, and then there's an update a year later. But in the case of this study, we did get an update at ESMO, which I'll share with you again in detail. So what was the PEACE study? So the PEACE study is really building on the knowledge we've got with abiraterone. We know that abiraterone is highly effective in helping control patients with metastatic disease in castrate-resistant disease and in the hormone sensitive setting as well. And PEACE-1 was investigating whether you could adding in abiraterone to the then standards of care made a difference. So the piece one was quite ahead of its time. It started enrollment in 2013, and I think it's important to note where were we when we started enrollment. So the standard of care for newly diagnosed patients with metastatic prostate cancer was hormonal treatment on its own. So we just gave patients an LHRH agonist on its own. That seems like quite a long time ago now, but in fact, it was only a few years ago. We didn't know the evidence for the use of docetaxel, so the charted and STAMPEDE data hadn't been presented. And abiraterone was what the most widely used therapy for castrate-resistant prostate cancer. And we had no idea that abiraterone improved outcome in patients with newly diagnosed disease. So this was really, this is the time point that we're in. So what was the design of the study? What was the design of the study? Again, has already been discussed. Patients were either offered standard of care, which would have been hormones. They were offered standard of care plus abiraterone, standard of care plus radiotherapy, or the standard of care plus abiraterone and radiotherapy. Now, who went into the study? And I think this is really, really important. Essentially, patients who did have significant burdens of metastatic disease. And actually, a lot of the patients in the study went on to receive docetaxel because of the movement in standard of care. So there wasn't really a group of patients that weren't represented in the study. And as we've seen, the progression-free survival, the radiographic progression-free survival was greatly improved. Now, one of the things that wasn't clear when this study was first presented was whether or not there would be any significant benefits to patients in terms of overall survival, and which groups of patients, and whether that benefit in overall survival was going to be restricted to some subgroups or whether it was seen with everybody. We know from the results of STAMPEDE, which aren't shown here, that there isn't a group of patients with low or high volume metastatic disease which don't receive have a benefit from receiving docetaxel if they have metastatic disease. And here in this study as well, if you received abiraterone, you can clearly see here, it didn't matter where you were at within your disease course or your burden of disease, there was a benefit for you having the abiraterone. And this isn't a new finding within the context of what we now know about the treatment of prostate cancer. In other words, if you use your most effective treatment earlier, you do better. But it doesn't suggest there's a group that shouldn't receive abiraterone in addition to docetaxel. Now, this again was the data from STAMPEDE. This was an indirect comparison of abiraterone versus docetaxel, and what you can see in this analysis here is that there wasn't any difference. We're just focusing on this top graph here in overall survival and an indirect comparison of patients treated within STAMPEDE. This wasn't a randomized comparison, but there were patients who were randomized into treatments which ran sequentially. And there wasn't any difference in patients' outcome if they received abiraterone versus docetaxel in the STAMPEDE study. So this then led to the question, well, does it really make any difference? Does it really make any difference to overall survival overall if you have this combination? And Karim Vazazi, he reappeared at ASCO with his colleagues, and what they showed was there was a benefit in terms of overall survival for the ADT plus docetaxel and abiraterone combination. So in other words, if you add in your abiraterone to your, to docetaxel, you get an improvement in outcome. So what can we conclude from the piece one study? Well, we conclude that adding in abiraterone to docetaxel appears to improve outcome. And the combination shows that it has a very, very long median overall survival. This is the longest overall survival advantage that's been seen in any kind of phase 3 study in prostate cancer. But it isn't clear to me if it's the combination of the therapy which is better or the sequence of both drugs. And this is really, really important because when we're thinking about what drugs are currently available, apalutamide in the Titan study, apalutamide was given in sequence with docetaxel in a minority of patients. And it is possible that it's not the combination, but the sequence is better. And that's important, I think, for many of us, particularly in the COVID era. We've actually switched away from using abiraterone because of concerns about the use of steroids in patients with COVID. And there are newer therapies which have come online like apalutamide and enzalutamide, which don't mean patients have to take steroids. So I think we need to know a little bit more about whether or not there's actually any synergy between abiraterone and docetaxel together, or whether the patients would do just as well if they had docetaxel first, followed by abiraterone, followed by apalutamide or abiraterone in sequence. The other thing to bear in mind is that the field has moved on to a degree, and there are now other combinations, for example, being tested like niraparib and abiraterone in amplitude in patients with DNA repair defects. Now, the final abstract I'm going to discuss is the VISION study, and this is a randomized phase 3 study of lutetium PSMA 617. This was presented by Michael Morris at ASCO. I think the first thing to highlight about this is Endocyte was funded, and it is essentially a Novartis product now. And I think this is really, really important for reasons I'll come on to. So who went into the study? Well, they had, as has already been discussed, extensive pre-treatment already. They were randomized to either have standard of care or have lutetium PSMA treatment. What were the endpoints? Well, it was progression-free survival and overall survival. Now, what's really, really important is that there was a significant improvement in response, and you can see the PSA response is really, really striking here versus standard of care. What does this mean? Well, if you've got somebody who's in this situation, this is a good treatment to put them on. They'll definitely have a much, much higher treatment response than you would do if you gave them anything else that was left available to you. You can see that the treatment prolonged overall survival by 15 versus 11 months. So there was a clear benefit here in favor of the treatment. And there wasn't a group really that didn't appear to derive benefit from it. Unlike other forms of systemic radiotherapy, this treatment does work for patients with liver metastasis. So when we're in our clinic, we have somebody who's got pre-treated disease. We know they're not very well, and they're coming to the end of their effective systemic treatments. And they're in that unfortunate position of developing liver metastasis or other visceral disease. We know that this treatment will help. So that's really, really important. The treatment, fortunately, there's been a proliferation of data in this area, and I think one of the things about lutetium treatment is what we've seen so far is typically has been is case series, large case series or small studies presented showing very dramatic responses, but there hasn't been much randomized data. The study with the VISION study is obviously a randomized study. There was also some data presented in recently early this year, and you can clearly see here an advantage for patients receiving lutetium over carbazitaxel, a standard treatment for advanced prostate cancer, castrate-resistant prostate cancer. So where does lutetium fit into lutetium PSMA 617 fit into the prostate cancer landscape? Well, it's definitely for some people, it's going to be prior to chemotherapy for those people with visceral disease, particularly those people who wouldn't necessarily tolerate chemotherapy, and for which there are, unfortunately, many men with advanced prostate cancer fit into that. We need to know where the resistance mechanisms are to lutetium PSMA, so that isn't clear at the moment. We also don't know what the best combination is. And then the other question really is, when will this treatment become widely available for use? For those of you who aren't aware, it does require an isotope generator. This is something which has been very widely done in Australia. And the important thing about this is a lot of this isotope generation has been bespoke. So in other words, it's people generate their own isotope, they then use it and they generate their own evidence base. But this is going to be, because this is a Novartis or a commercial type treatment, it's going to be able to be licensed and widely available. And then the other thing about it is that it will be supported by a major pharmaceutical company. And that's going to be really, really important, because the treatment's going to change from being available just in special places to becoming much, much more widely available. So I'm going to say, look, it's been a pleasure to discuss these abstracts. Huge changes in the standard of care in all of the areas that we've discussed. And I look forward to discussing these with you all a little bit later. Thank you.
Thank you, Dr. Mark. And now we're going to move to the keynote lecture, the adjuvant therapy in urothelial cancer.
Great, thank you. I'm just going to change the presentation over. Just to confirm that you can still see my screen.
Yes.
Sorry, my apologies. I haven't done very well at starting my presentation at the beginning slide, so I'll do my best next time. Thank you. So look, it's a great pleasure to give you an update on the adjuvant therapy in urothelial cancer. This is an area which is of great interest to us, and I think that the first reasons is that patients with urothelial cancer tend to have a very adverse disease course, and secondly, there hasn't been much progress in this area for some time. These are my disclosures. So what are the learning objectives for the talk today? It's a history of the development of adjuvant systemic treatments of urothelial cancer, and it does spread out over quite some time. Current approved adjuvant therapies, ongoing research, and some key outstanding questions in this area. So the history of adjuvant therapy in bladder cancer actually goes back, or urothelial cancer, goes back almost over 100 years with Camille Guerin and Albert Calmet, who did the initial work in the Louis Pasteur Institute in France. And what they did is they purified different strains of BCG. And you can see here in this top corner here, the different strains were developed. And there was a huge amount of interest in the last sort of 100 years on mycobacteria, because it was discovered that patients who had TB tended to have a less severe course if they were to develop cancer. So BCG was developed and has now become a standard of care for non-muscle invasive disease and reducing recurrence after resection. So we start our journey, if you like, almost 100 years ago now, with these two scientists doing their initial work, and these strains have been purified and used ever since. Now, where do we start with our adjuvant treatments? Well, we start really with some randomized data in 2003, and this is by Grossman et al. And this is looking at neoadjuvant chemotherapy prior to patients having a cystectomy to remove their bladder. And what you can see here is the chemotherapy is MVAC versus cystectomy alone, and there's an improvement in overall survival in these patients. Now, what does that mean? Well, it means at the time that was the then standard of care, and what they showed in this study, I mean, this is a very, very old data now, but if you had some residual disease afterwards, you did much worse, and if you had a complete response, you did better. This was then followed, because there were lots of other similar studies by a variety of different meta-analysis, and I'm just showing one here from the UK. And this showed that if you combine lots of different studies, including the one by Grossman et al., you can see an improvement in outcome if patients receive neoadjuvant chemotherapy, that's platinum-based chemotherapy, and prior to them having a cystectomy, they do better. And again, what you can see here is you can see an improvement in overall survival. Now, and in this slide here is pretty much where we've got to until, relatively speaking, recent times. So in other words, if you take somebody who's got a new diagnosis of muscle invasive bladder cancer and you offer them chemotherapy before they have surgery, you improve their outcome. Adjuvant treatment is also considered, and we do sometimes do that afterwards. However, most patients who've had a cystectomy for bladder cancer, as I'm sure everybody is aware, they're often unwell afterwards and aren't necessarily fit for further systemic treatment afterwards or systemic treatment afterwards. Now, this is some data from an EURTC study, which looked at whether you should have deferred or initial chemotherapy. So in other words, did the chemotherapy actually improve your outcome if you had it before or after your operation? And the answer is yes, if you've had definitive treatment, you should have your immediate systemic treatment afterwards or beforehand. So in other words, the benefits of the treatment aren't seen in urothelial cancer just because they're good at treating metastatic disease. They're seen because they treat micrometastatic disease and they improve outcome. Now, however, if you're node negative at baseline, so you don't have any lymph nodes, say, around your bladder, the deferred treatment is clearly inferior to having immediate treatment. But if you're node positive at baseline, you clearly have there's no difference in outcome. So in other words, if you have a node positive urothelial cancer being diagnosed within your bladder, you're at very, very high risk of having metastatic disease. And any kind of treatment will improve your disease-free survival, but is unlikely to make a big difference to you. Now, that was the then standard of care up until quite recently. And that's despite years of really research, trying to look at different combinations. And where we've got to in the UK and around the world is that some people have been using accelerated MVAC, which is over within 6 weeks, and other people use cisplatin and gemcitabine. And wherever you are in the world, you'll have your own variation of that sort of standard of care. Now, one of the things is that although we think of urothelial cancer as predominantly a disease of the bladder, which is the most common, the common site of urothelial carcinoma, other places you can get it include the upper tract of urothelial carcinoma. And the adjuvant treatment for upper tract urothelial carcinomas is highly important because these tumors tend to have a high recurrence rate and risk of relapse after surgery. And there's been conflicting data with retrospective data showing improvements after an nephrectomy in the neoadjuvant or adjuvant treatment for upper tract urothelial cancers. So the POUT study, which was published in 2020, we took part in that in Oxford, and it was set up and run in the UK, looked to recruit patients who'd had a nephrectomy for upper tract urothelial cancer. Who went into that study? Well, you can have a look at the study schema here. I'm not quite sure how well this is presented, but essentially, if you'd had a radical nephroureterectomy, so in other words, you'd had your kidney and your ureter removed, essentially your patients are randomized on a one-to-one basis to receive either 2 sets of chemotherapy. One is gemcitabine and cisplatin for 4 cycles, or gemcitabine and carboplatin if your GFR was 30 to 49 millimeters. So that would be our, normally our cutoff would be 60 millimeters, but they pushed it down to below 49 in the study. So this is a very pragmatic study. It's talking about chemotherapy very, very similar to the first study that we first presented. What we could see in the POUT study, there was an improvement in disease-free survival here, which is seen here, and an improvement in metastasis-free survival. Now, it's important to note this is a small study. If you look at the numbers of people who went into this study, we're looking at 129 versus 131. Why was that? Why? Well, actually, it's very difficult to recruit to this study. These patients only make up a minority of patients. Nevertheless, this is a significant benefit in disease-free and metastasis-free survival. Now, again, it's very, very important to stress that forest plots and looking at subgroups in very, very small numbers of patients cannot be relied upon. But what we can see here is it does appear to be an advantage for the patients receiving chemotherapy. Again, patients who had the cisplatin and gemcitabine seem to do a little bit better, but I must be cautioned on interpreting of this because all the groups went across to the left and they're very, very small. So there wasn't really a group which you would say in the study wouldn't get benefits for having this treatment. What about quality of life? Well, the quality of life did dip when patients having chemotherapy, but was okay again afterwards. What's my conclusion for POUT? Well, we've concluded in the UK that adjuvant platinum-based chemotherapy with either cisplatin and gemcitabine or gemcitabine and carboplatin for those patients with inferior renal function is now a standard of care for patients. Is one of the questions about this is the lack of overall survival a problem? Well, I don't think so. I think from a practical point of view, if somebody does get metastatic upper tract urothelial carcinoma, their outcome is poor. And I think from a practical point of view, we've started using this in the UK now and accepted this as a standard of care. And again, I welcome discussing that with my fellow panelists this morning. The other thing to be aware of is that we haven't really moved the needle very much. Really, all we've done is in the POWER studies, we've shuffled around similar therapies than that which I first presented in it was first being developed in 2003. So all we've done is we've shown that the things that we thought were reasonable to do in the past were acceptable to do now. Now, one of the things that's happened, and I'm not going to show a lot of data on this, is over the last sort of 5 to 10 years, there's been an explosion of immunotherapy in the treatment of urothelial carcinoma, and this is within the metastatic space. And what can we see? And so this has led to adjuvant studies of immunotherapy. So adjuvant atezolizumab, an anti-PD-1 inhibitor, that's been tested in reducing the risk of recurrence after treatment or definitive treatment for metastatic urothelial, after definitive treatment for urothelial carcinoma. And this study was negative, and there was no improvement in overall survival. So not everything that's been tested in adjuvantly makes a difference in patients who've had definitive treatment. Now, the most important data I'm going to talk about today is adjuvant nivolumab versus placebo in muscle-invasive urothelial carcinoma. And this data have been published in the New England Journal of Medicine and presented earlier on this year at ASCO. Now, as we've discussed already in the talk, radical surgery is the standard of care for patients with muscle-invasive urothelial cancer. And essentially, there aren't any recommended adjuvant treatments. So essentially, if patients who've had got bladder cancer, they're recommended to receive neoadjuvant treatment. And there are some people who receive neoadjuvant treatment who then have residual disease afterwards, and there are patients who are unexpectedly found to have muscle-invasive bladder cancer that haven't received adjuvant therapy. And then the other thing is that once patients have had a cystectomy, the prospect of them receiving, say, cisplatin or accelerated MVAC afterwards is often too much for them. And there are no approved treatments if you've had your definitive treatment. So nivolumab is an anti-PD-1 checkpoint inhibitor. It's approved as a monotherapy for the treatment of platinum-resistant urothelial carcinoma. In the UK and in Europe, it's phase 2 data, and as a result, it hasn't been able to be approved in the UK for use. And what I mean approved, I mean in the UK we have kind of 2 systems, if you like. We have the public system, which makes up 90% of the prescriptions of medicines. And although the drug's licensed, it hasn't been approved for NHS use based around cost effectiveness, although it is licensed by the European Medicines Agency. And at the time when the Checkmate 274 study was published, there hadn't been any other immune checkpoint inhibitors which had shown improvements in outcomes in patients with muscle-invasive urothelial carcinoma that are at high risk of recurrence after radical surgery. So the Checkmate 274 study is really a revolutionary study in this regard. So when we're thinking about standards of care, who went into the Checkmate 274 study? Well, patients who'd had previous neoadjuvant chemotherapy, they could have had any staging of disease, but it's PT2 to PT4A, and including patients who had node positive disease as well. And these patients were able to go in who without prior neoadjuvant treatments, who weren't eligible for adjuvant platinum-based chemotherapy. They had to be disease-free within 4 weeks of dosing, which is not unusual. And the radical surgery could have been within the past 120 days. And that's quite important. If you've had a big operation like a cystectomy, patients need time to recover from it. Now, when we're thinking about the study treatments that they were offered nivolumab, 240 milligrams every 2 weeks. That will obviously be changed when we actually come around to using it. And they were treated for up to a year's worth of adjuvant treatment. Now, what were the baseline characteristics? And I think that's really, really important. So the patients were predominantly men who went into the study. That's not unusual. And they were recruited quite frequently in Europe and from around the rest of the world. The patients are pretty well, really. Most of the patients are PS0. So in other words, these were very fit patients that we would typically associate with the study, but some were PS1 and there were very few PS2 patients. The majority of the patients had muscle-invasive urothelial carcinoma arising from the bladder. However, they did include patients from the upper tract, which is extremely welcome given the adverse disease course that these patients often have with upper tract disease. They had quite a lot of the patients had PD-L1 high, and most of them had previous cisplatin. So in other words, they were pre-treated patients. And again, a few of the patients were PT0, but the majority of them had some residual disease, and quite a lot of the patients had node positive disease as well. And I think that's really, really important. So this is just the sort of the summary slide, if you like, and what you can clearly see here is that the disease-free survival was in the intention to treat population, and what we mean by that is all the patients who went into the study. That was clearly higher at 74.9% versus 60.3%. That's a really big difference. When we're thinking in our in adjuvant treatment land, we often say that a 5% or 5 people in 100 benefit is significant, and that's around the benefit we get with standard adjuvant platinum-based chemotherapy, give or take a few percentage points. So this is a striking benefit, and that benefit was also seen extremely highly in patients who've got PD-L1 positive disease, with almost 20% improvement there as well. And this is perhaps, this is really, really important. So in other words, actually, there's a group of patients who do get substantial benefit from this, this treatment, and importantly, their disease-free survival was also improved. Now, if we have a look at the disease-free survival here, you can clearly see here the curve separate, with the patients receiving nivolumab doing better than those patients who received the placebo. And again, and that disease is more, the benefits are more striking in patients who are PD-L1 positive. Why is that important? Well, it does give us an indication of which groups of patients may do best. However, it's important to note that these PD-L1 positive patients only make up the minority of patients, and there's clearly a benefit for all comers. Again, this is another analysis of the same thing. So if we have a look at the disease-free survival in selected populations, I know the colors are slightly difficult in this background. So again, you can clearly see on this forest plot here, there is a clear benefit with all of the curves here going across to the left-hand side of the graph, all of the points rather going over to the left-hand side of the graph. There wasn't a subgroup of patients who didn't appear to get benefit from having adjuvant nivolumab. What about the side effects? Well, actually, they're very, very similar to what we'd expect from nivolumab now. For those of us who treat urothelial carcinomas, particularly kidney cancer and bladder cancer, we've got used to treating patients with checkpoint inhibitors. And again, rash, diarrhea, itching, fatigue. Again, these are all side effects which are relatively speaking straightforward to manage. There was no new safety signals. And again, it's important to note for quite a lot of these patients, they would have had to have received some of these medicines anyway. So there's no new safety signals here within the study. And again, this is just a tabulated version of the same side effects here. What's really, really important is that the majority of patients did get some adverse events. So this isn't a completely risk-free treatment. However, again, if we look at the breakdown here numerically, you can see there's nothing on here on this graph that would say to you, I wouldn't use nivolumab because there were any great concerns. Now, what about quality of life? Well, actually, there wasn't any different change in quality of life here in the study. And I think that's really, really important. Bladder cancer or muscle-invasive urothelial cancer is something which has a big, big effect on patients' quality of life. Having a cystectomy, for example, is a big change. Having the bags and all the other aspects and the major operation is a really, really big thing. And when you see somebody who's had this operation and their pathology is unfavorable, to then be back in the clinic and you say, well, we've got a treatment we can give. And they're like, oh my gosh, do I really have to have any more treatment? You say, well, actually, we can reassure you that your quality of life won't go down afterwards. So in other words, you should, although you'll get some side effects, patients in the study didn't report feeling any worse than those people who were in the, who didn't get the same medicine. So I think we can be reassured that having nivolumab won't change patients' quality of life afterwards. So what have we learned from Checkmate 274? I think the first thing we've learned is that we've now got, I mean, this is a real landmark analysis. We've now finally got a treatment which is different from platinum-based chemotherapy, which can improve outcomes in all groups of patients with muscle-invasive urothelial carcinoma. This is an effective treatment. It's well tolerated, and we're obviously familiar with it from our other use in other conditions. There wasn't any change in quality of life. So if you're one of those people who unfortunately needs this treatment, you can be reassured that we can reassure our patients that their quality of life will be good. And this is the first systemic immunotherapy treatment which has shown an improvement in outcome. So really, when we're thinking about this treatment, what have we really done with this study? So essentially, we've gone, I was tempted to call this talk back to the future. Really, what we've done with the nivolumab here is we've taken it's taken us about 100 years to get from a superficial immunotherapy, that's BCG, round to a systemic immunotherapy that we can then give to patients. Now, is this the last word? And the answer is, I'm delighted to say no, although the addition of nivolumab into the clinic is going to be extremely welcome. There are other treatments which are ongoing here. So there's the Ambassador study, which is going to be testing pembrolizumab. I think we can expect similar results from that, although it's difficult to predict. There is different treatments going on with combinations of nivolumab with radiotherapy. There's enfortumab, vedotin, and pembrolizumab. There's neoadjuvant treatment. So that's really enfortumab vedotin, for those of you aware, is an antibody against Nectin-4. With a bit of chemotherapy stuck on the top, and that's going to be tested plus pembrolizumab as neoadjuvant treatment. So that's essentially looking at molecularly targeted chemotherapy and immunotherapy. There's going to be some adjuvant IMRT studies. There's going to be FGFR inhibitors as well being tested. We talked about a role of atezolizumab. And I think really, really importantly, we're going to be looking at double checkpoint inhibition with durvalumab and tremelimumab as well. So in other words, previously, platinum-based chemotherapy was the kind of sort of the beginning and the end of this. We've now got other combinations, and bladder cancer immunotherapy and adjuvant treatments has gone from being really a sort of backwater into an area which is closely contested now. And there are many other treatment options, and this is going to be really, really good for our patients, because now, if you're one of these people who unfortunately gets bladder cancer, which is a really, really difficult to treat condition once it's spread, actually your outcome is going to be much, much better if you receive adjuvant immunotherapy. And the future for this is very, very bright. So what are my conclusions from this talk? The first is that adjuvant nivolumab improves disease-free survival in patients who've got high-risk muscle-invasive urothelial carcinoma who've had radical surgery. We're waiting to see the overall survival data, but I'm sure that will be encouraging, or it's very likely to be encouraging. We've seen that platinum-based chemotherapies improve disease-free survival in upper tract urothelial carcinoma. And we need newer combinations of therapy, which are thankfully in development to prevent relapse in IO-resistant patients. And the really, really great news is I'm confident that ongoing research is likely to further improve the standards of care for our patients with urothelial carcinoma over the next 5 years. So with that, I'm going to stop, and I'd be delighted to take any questions along with my fellow panelists. Thank you.
Thank you very much, Professor Total. And now we have one more. Oh, okay. So we'll go with the questions. I'll ask Dr. Al-Ghamdi, please, to join us on the podium here. And if anybody from the panelists, they have any comment or question, maybe Faisal is very keen to comment on Fahad bin Shamsa.
Thank you, Sam.
Okay, so
actually,
please, Faisal, go ahead.
The talks were excellent. I really enjoyed it. All of you did a very good job. I have a lot of questions, but I don't think so we have much time. So the question actually is for Imad rather than Fahad and Mark. So I'm quite confused about the Peace 1 study, where you said the triple regimen improves the survival, very recently presented in the ESMO trial. This was not pre-planned, am I right? Because in this study, they have changed the standard of care And then they commented or concluded that it improves the survival if you add docetaxel to abiraterone ADT. And how do you compare this with Enzamet study, where it was pre-planned study? They have included docetaxel added to the enzalutamide and no overall survival benefit. So either of you, Mark or Imad, how would you say about this? Thank you.
So it's an excellent question. And I'm sure you treat prostate cancer, you know what exactly is happening. So I'm going to dissect your question into 3 parts. First part, you talked about the triplet therapy. So the triplet therapy in this have clearly demonstrated there is overall survival benefit, which was pre-planned in terms of the co-primary endpoint. One of them is rPFS, the second one is the overall survival. So this is point number 1. Point number 2, now if you say back in 2013, docetaxel was not included in this therapy, then yes, you're correct. But the authors have amended their protocol because of the evolving in the current literature that docetaxel was now part of standard of care, and they have added docetaxel to standard of care. The third point, which is the Enzamet, you're absolutely correct. Enzamet, like if we talk about what are the concurrent docetaxel trials, so PEACE 1 is one of them, which have shown overall survival improvement. Enzamet did not, where they used concurrent docetaxel. And the third ongoing trials, which will be waiting for the analysis, is the Arasense, the darolutamide. So you do have a point here, and I'll also ask Mark to comment further.
So thank you. That's a very, very good point. So I think the first thing I'd say about the design of the PEACE 1 study, this was an academic study. So it wasn't designed as a registration study. So they were able to sort of move the goalposts, if you like, and move the analysis as time went on. So in terms of the Enzamet study, I think it's important to stress that enzalutamide and abiraterone are actually quite different molecules in how they work. There's quite a lot of preclinical, there's quite a lot of phase 2 data showing very high response rates if you add abiraterone to chemotherapy, for example. Now, but there's also data showing that bicalutamide, if you add in bicalutamide to chemotherapy, it makes it less effective in the CRPC setting. So I wasn't surprised that Enzamet was negative because of the way the drugs work, because enzalutamide definitely, it actually directly inhibits androgen receptor binding, and in fact, it inhibits the transcription factor, the androgen receptor transcription factor. So I think the drugs are different. But I do take your point in that it wasn't a pure study which looked at the interaction between enzalutamide, so abiraterone and docetaxel. So I think this is an area we need to have a little look at, and we need to have a little look at whether the combination is actually better than giving the drugs in sequence, because actually there are alternatives available which you can give in sequence now, because I don't personally believe that the abiraterone docetaxel combination is going to be approved for use therapeutically. So it won't be, I don't think it's going to be licensed or it's going to be NHS approved in the UK. So I don't think we're going to be able to use it in the way that has been demonstrated in the study. I hope I've answered your question.
Thank you.
Just let's have some discussion about the adjuvant treatment for renal cell carcinoma. Maybe I'll start with Dr. Faisal. So what's your view on the current evidence and the practice for using adjuvant treatment in high-risk renal cell carcinoma?
I personally haven't used it. We have quite a few trials in the TKIs, which has shown some responses. Mostly is the relapse-free survival, but no overall survival. There are studies which are negative for pazopanib. There are studies, some positivity in the sunitinib. And now we have pembrolizumab. Personally, I'm still a bit reluctant to start because of the toxicity profile. And we've seen from the sunitinib study, the adverse events were significantly higher for the benefits we are getting. Similarly here, I would wait actually to see if we get any overall survival benefit or not. But for the time being, I'm not much in favor of it, and I haven't personally given it to any patient.
Right. I'll tell you a terrifying story that I had with the first patient. I've used sunitinib as adjuvant treatment for him. He had all the common, the rarest side effects, including actually his hair after the first cycle became completely gray. Young man, he was 35, so I was terrified. But then I've used it for 2 or 3 patients based on their request, bearing in mind the toxicity. And also another thing, Mohammed, so also I know that you have certain views on this.
Thank you so much. So when we look at the adjuvant pembro, it's similar story to the Star Trek, right? The adjuvant Sutent. So it was positive and the disease-free survival, but no overall survival yet. So I agree with Faisal, I agree with Fahad, and Fahad summarized it very nicely at the end of his presentation. And I think waiting for robust data on the overall survival will encourage us to use it in the adjuvant setting. However, at the time being, even pembro, if pembro is less toxic than Sutent in the adjuvant setting, there is also financial toxicities, right? So probably more data are warranted before taking the decision.
Right, financial toxicity. That's a wonderful term. Dr. Mark, your comment?
Oh, well, look, I thank you for your comments. I share your concerns about the Sutent data because it was universally negative. I think my comments on Sutent is that it's really a cancer growth inhibitor. It doesn't really change anything in terms of, it doesn't get rid of anybody's kidney cancer. Nobody gets cured with Sutent. I think for the adjuvant pembrolizumab, and I think we've been recruiting patients to the Rampart study in Oxford, and I think we've now recruited 17 patients, and it's a non-randomized study. It's non-blinded study, so we're aware of what patients are having. So far, we haven't seen anything that would put me off this treatment in that study. So I'm from as we go along with this and giving patients checkpoint inhibitors in both the in the advanced disease setting and early, I think this definitely deserves consideration. I do share everyone's concerns about the cost of these treatments because they are quite significant. In the UK, we have mechanisms for keeping the costs down. The government essentially have a cost effectiveness discussion with the relevant pharma companies as a payer. So we have a mechanism for keeping our costs down. But I personally, I think if it was to become available, I will use it. But I agree there's going to be differing opinions on that within the field.
Ahmad Abdurrahim, do you have any comment on this matter?
Yeah, I agree with the comments I was saying, mentioned by our colleagues. The cost is one thing. Like the sunitinib, the same concept. You give treatment for 1 year to prevent it for 1 year or to delay it for 1 year, and still until we have final data for that, I think I'm not now very pro adjuvant pembro in this setting.
The only comment I have is if we start adjuvant pembro, so what do we do next?
Okay, that's another.
Well, Assam, if you allow me.
Yes, please. I was coming to you, Fahad.
Thank you very much. So, despite that all being said, and the need to have overall survival benefit in this setting, which everybody is agreeing, I think this is a very valuable study. It's very welcome study. This is a very good advancement in the treatment algorithm and understanding of our approach to kidney cancer. We've done a lot of things in the metastatic setting. Now we have very effective treatment, and I think the keynote study is an excellent study, much better designed than the SUTENT studies, and that's natural progress, of course. I totally agree that it should not be standard of care now for everybody, but if I am going to use it, I will use it for the higher risk patients, which is the residual disease, M1 with no residual disease, and the T4 patients, because those patients, they are the ones who achieve the best benefit regarding disease-free survival benefit also. I totally agree with you, Issam, when you started that it was based on patient request. And it's the same story with me. All patients that received adjuvant treatment RCC, they were very well informed and they wanted treatment. Of course, we explained to them the controversy. And also another thing to put in mind that there are other adjuvant studies that we're still waiting for, and they will add to our insight in this setting. Thank you, Issa.
Thank you very much. Maybe we'll close the discussion with one more comment. I'll take just a very short from everybody about, I know the usual question is that what's your preferred approach in the first line metastatic RCC? So I will start this time from the online guys. We'll start with Ahmad, and then Abdurrahim, Fahad, Dr. Mark, and then we will go to the panel here. So in just few words, Ahmad, start, please.
I'm sorry, I missed. Was there a question or just comment?
Yeah, what is your comment on your preferred approach? Okay, let's put it this way, not regimen, for first line metastatic renal cell carcinoma, and why?
All right, so you put me on the fire. So I'll use that based on intermediate, based on the risk group. So if I have intermediate poor, definitely I will go with the Nivo Epi. If I have other options like good risk, intermediate, and all risk, I think combo. TKI and immune.
Okay, Abdurrahim.
So we have a lot of good options. For me, and favorable risk, I like dual immunotherapy. And for the good risk, we know that they're going to do regardless. So either a single agent TKI, or maybe, I think of immunotherapy and TKI, but maybe TKI for the good risk and dual immunotherapy for unfavorable.
Fahad.
Yeah, for favorable risk, I think they do well with whatever treatment you give. And I'm not inclined to give combo for favorable risk. For intermediate poor risk, intermediate maybe TKI with IO. More towards poor risk, I have some preference to the IO double blockade. And you know what? We have at the end, we have to accept that we have several options with no clear difference. My colleague, Dr. Leonidas, who's an oncologist in Dammam, he calls it the embarrassment of rich, and I'm happy with that.
Dr. Tadhil?
So I think we've had Ipi-Nivo available sometimes. So I think for intermediate or poor risk, if the patient is very well, in other words, they aren't feeling very sick and aren't declining rapidly, and our standard of care is Ipi-Nivo. For the good risk, it's avelumab and axitinib, because we don't have funding on the NHS yet for pembro axitinib. I think for somebody who's got poor risk disease and is poorly, then my standard of care is to put them on axitinib and avelumab, because we quite often see rapid responses. But I take the point. It is an embarrassment of riches, and no matter what we do, if you've got somebody who's not very well, if you put them on a TKI, so axitinib plus or minus avelumab or pembrolizumab, they will respond rapidly. So I think either of the options are very good, and I think this is going to be something we're going to be talking about for some time to come yet.
I'm going to talk about it in a minute anyhow, but what I do in clinical practice is that those patients who have high burden disease and symptomatic, I prefer to give combination of TKI with the immunotherapy, either XC plus pembro. I've given more, but lenvatinib recently we have added to pembrolizumab. But otherwise, other patient NIPI, IP plus Nivo.
Yeah, Mohammed.
Thank you so much. So I would agree with my colleagues, especially Faisal. But remember, we don't have access to all medications. So probably just focus on one or two options at your center and get familiar with this. Thank you.
Thank you very much. Before we go, I'd just like to say that when you have one option, okay, everything is easy. When you have many options, it's difficult. I say it's like an airplane flight that you are going on autopilot for a long time and you are very happy with it, and all of a sudden you will have this tornado coming, and then you need to go and to pilot the plane yourself. Sometimes you may get confused because the longer time that you have spent on autopilot, you may forget actually how to fly a plane. Thank you very much, everybody. And now shall we break or we go immediately? Okay, so we'll go with the satellite symposium, and I'll leave you with the first one for PMS and Dr. Azam.
Thank you all.
Thank you.
Okay, Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me. So the scientific committee, Dr. Isam and Marwat, and also the BMS who have asked me to talk about the dual immunotherapy combination in metastatic renal cell carcinoma. So this satellite symposium is basically sponsored by BMS. We have already discussed quite a few things about how to manage the metastatic renal cell carcinoma, but my talk is basically just about the combination of immunotherapy. These are my disclosures. So why is it important to treat the metastatic renal cell carcinoma? Because of the prognosis poor of these patients with 5-year survival of only 12%. Most of the relapses happen within first 3 years, and 40% of these patients will die of metastases. So there's an unmet need to improve the survival of these patients. We are targeting are the VEGF pathway through tyrosine kinase inhibitors. We have mTOR inhibitors by using mTOR pathway, where we are using mTOR inhibitors. We have PD-1 and CTLA-4, which are the immunotherapy drugs. So, and then the combination of both has been tested. And this is what I'm going to discuss in more detail. I'm not going to discuss the mechanism of action because these are not new and most of us know about it. So those patients who have a favorable risk disease for metastatic renal cell carcinoma, they usually do better regardless of what treatment you give. Their survival is comparatively better than those patients who have intermediate or poor risk disease. And this is the group of patients where we definitely need to do something to improve their survival. So the immunotherapy was first tested in second-line setting for metastatic renal cell carcinoma. They've used the single-agent nivolumab versus everolimus, which was at that time a standard of care in second line. And better, why not one single agent immunotherapy works better? Why not combining the two different drugs? So that might do even better. So the first trial that was done was Checkmate 067 in metastatic melanoma. So I also treat metastatic melanoma, and I must say that before the so is the progression-free survival was significantly better for combination of EP plus Nivo as compared to the nivolumab alone or ipilimumab alone. The best part of this study is the objective response rate of 58%, which was not known in metastatic melanoma before this trial. Nivolumab 45% and ipilimumab alone 19%. And then complete responses of 22% was excellent. This is, as I mentioned to you, 1 year survival for metastatic melanoma before the immunotherapy was hardly 10 to 15%, and now we are talking about complete responses of 22%. And over the years, this has improved. So at the analysis from this trial at 3, 4, and 5 years, the complete responses improved at as 19%, 21%, and 22% respectively for Nivo plus Ipi. So this was basically the start point for this combination. And so it was tested in first-line setting for metastatic renal cell carcinoma also. So Checkmate 214 has already been discussed briefly, but this is basically the study where they have recruited patients who have intermediate or poor risk disease. As I told you, this is the group of the patient who have the worst prognosis. And this time the dose they've used is different than melanoma. Nivolumab 3 milligram per kilogram plus ipilimumab 1 milligram per kilogram for 4 doses. And then nivolumab was continued till progression or toxicity. The second arm was sunitinib, which was standard arm of giving 4 weeks on, 2 weeks off. More recently, just a few days ago in ESMO, they have reported a 5-year follow-up data from the Checkmate 214 study, and also a conditional survival has been reported. So these are the results from Checkmate 214 study, the analysis at 17.5 months, 30 months, and 42 months. All the overall survival, all favoring combination of nivolumab plus ipilimumab as compared to sunitinib alone. The median was not reached in first 2 analyses, but at 42 months, it was 48.1 months versus 26.6, hazard ratio of 0.65. Then few days ago in ESMO conference, it was reported that the median overall survival remained same or better after 5 years. Median overall survival was 47 versus 26.6 months, favoring Nivo plus Ipi, hazard ratio of 0.68. Subgroup analysis reported almost all those patients benefited in terms of overall survival when they received Nivo plus Ipi. That is regardless of the age, gender, previous nephrectomy, PD-L1 expression, bone metastases, liver metastases, lung metastases, or lymph node metastases. Another endpoint was progression-free survival in intermediate or poor risk group. And again, it was significantly better in those patients who had Nivo plus Ipi as compared to sunitinib. And you can see here at 42 months, the median was 12 months, versus 18.3 with the hazard ratio of 0.76. Another important point I want to stress here is the at 30 months, you can see the graph, the survival curve, progression-free survival curve plateaus, and it remains the same. So that means those patients who have progression-free at 30 months, most probably this is what they have achieved, and they shall remain for long term like that. Then in ESMO few days ago, progression-free survival at 5 years was reported. Again, similar results. Median was 11.6 versus 8.3, hazard ratio of 0.73. Objective response rate in intermediate and poor risk, it was 42 versus 26. Complete response is 10%. In ITT population, it was 39 versus 33. Complete response is 11%. But the story is different for favorable risk. The response rate was much higher with sunitinib and not with nivo plus ipi, 54 versus 29. But if you can look at the complete responses, the blue bar, it's 13%. So this is what I said, the favorable risk group patient do better regardless of what treatment they get. Toxicity, when we give combination of CTLA4 and PD-1 inhibitors, we expect that there will be more toxicity, and we have learned from the melanoma trial that this combination is really toxic, but this is different because the doses are different, and so the toxicity profile is different in this trial. Any grade treatment-related adverse event were 94% for nivo plus ipi versus 98% with sunitinib. Grade 3, grade 4 were 48% nivo plus ipi and 64% more with sunitinib. Discontinuation because of the treatment-related adverse event were 23% with combination of nivo plus ipi versus 13% with sunitinib. And the quality of life of those patients who had nivo plus ipi was comparatively better than sunitinib. On the right side, you can see here the grade 3 or more severe toxicity of diarrhea, fatigue, PPE, hypertension were significantly more in sunitinib arm as compared to the nivo plus ipi. Overall survival in those patients who stopped the treatment because of toxicity or treatment-related adverse event, and you can see here, so those patients who even stopped the treatment, their survival is better as compared to sunitinib. So that's why the duration of response here is important with any immunotherapeutic agents. And quality of life, as I mentioned, was better as compared to sunitinib in those patients who received this combination. So from the results of the Checkmate 2 and 4, this is the study where we have the longest follow-up period. We said, it has been reported that overall survival benefit has been seen in intermediate or poor risk group. This is the group of patients who have worse prognosis. Progression-free survival and objective response rate were also significantly better as compared to sunitinib. Also, the quality of life of these patients is better than sunitinib. Then a conditional survival outcomes were reported also. That means the initial assessment was done at 3 months, and they did the analysis of probability for the next 2-3 years. What will happen? So with the nivo plus ipi at the initial 3-year assessment, the survival was 66%, and it improved to 79%. And if you look at the conditional overall survival, it was 79% versus 72% favoring ipi plus nivo. Similarly, progression-free survival, the conditional progression-free survival was 90% versus 62%, and also the duration of response or the probability of remaining in response was significantly longer with ipi plus nivo, 90% versus 88%. This thing can be explained better here. On the left side, you can see here the curves which we mentioned conditional overall survival. With the red one is ipi plus nivo is, as you mentioned, 79% versus 72%. And then conditional progression-free survival was 90 versus 62%. And conditional responses were 90 versus 88%. So all favoring using nivo plus ipilimumab. I just want to discuss something else also. This is the group of the patient who have even the worst prognosis. Now, this trial have looked into one of the worst group of patients anyhow, intermediate and poor risk group. But now those patients who have sarcomatoid feature, they have a really poor prognosis with a short-term survival. So they did the exploratory analysis for those patients who had sarcomatoid features, and they found there were 115 patients who had sarcomatoid features. 60 of those were in the Nivo plus Ipi arm, and 52 of them were in the sunitinib arm. The left side of this table is for those patients who had sarcomatoid features and intermediate and poor risk, while on the right side, all other intermediate poor risk group. The baseline characteristic, if you look at it, is pretty much stable or balanced in both these groups. The objective response rate for sarcomatoid, patient with sarcomatoid feature was 56.7% in those patients who had Nivo plus Ipi as compared to 19% for those who had sunitinib. This is in those patients who had sarcomatoid features, while in the overall group, it was 42% versus 29%. So it's improving the responses for those patients who have even the worst prognosis. Complete responses, another important point to notice here is 18.3% of the patient had complete responses in sarcomatoid group and with intermediate and poor risk group. For overall intermediate and poor risk group, it was 11.3 versus 1.2. So significant improvement in objective response rate, significant improvement in complete responses. Also, the partial responses were better in the sarcomatoid group of patient. Progression-free survival, the median for those patients who had sarcomatoid, intermediate or poor risk disease was 8.4 months with Nivo plus Ipi as compared to 4.9 with sunitinib, hazard ratio of 0.61. 12 months, 24 months, and 30 months probability were all higher with Nivo plus Ipi as compared to sunitinib. Similar story with overall survival. The median was 31.2 months versus 13.6 months, hazard ratio of 0.55 in those patients who had sarcomatoid features with intermediate and poor risk disease. Again, 12 months, 24 months, and 30 months probabilities were much higher with combination therapy as compared to sunitinib. So the current recommendation to use Ipi plus Nivo is the doses we use here is nivolumab 3 milligram per kilogram with ipilimumab 1 milligram per kilogram. This is opposite to what we used in the melanoma, four doses of combination. And after that, the recommendation is to give either 2 weekly 240 milligram of nivolumab or 480 milligram of 4 weekly nivolumab. This treatment or nivolumab should continue till progression or unacceptable toxicity. In my experience, patients usually respond very well, and I have few patients who have been on nivolumab without any toxicity for nearly now 3 years. The most recent NCCN guideline, that is for 2022, basically, and they are recommending for poor and intermediate risk ipilimumab and nivolumab as category 1 preferred treatment. Also, if you look at the favorable risk, even in the other recommended regimens, they have mentioned that this treatment can be offered. And then in subsequent therapy, again, if it is not given in the first line, it can be offered. So it can be offered in first line or even in the later lines if it is not given. So just to conclude my talk, Checkmate 214 of ipilimumab plus nivolumab has looked into one of the worst group of patients with intermediate or poor risk who have a poor prognosis. And then further, they have done an exploratory analysis in those patients who have even no hope or really worse prognosis or survival, that is with sarcomatoid features. And they have found improvement in overall survival, improvement in progression-free survival, objective response rate, more complete responses, and then looking at the conditional survival analysis of progression-free survival and overall survival were significantly better in combination with nivo plus ipi as compared to sunitinib. So this is, as we all the panel and our speakers today, they all prefer to give this combination. So it's well known to all of us. And one of the reasons is because we are much more aware of this combination for the last few many years. And we know this is the only trial which has a data of more than 5 years now. And that was my last slide. Thank you very much. So I think the next speaker, I have 10 minutes. So if any questions, so we can take the questions from audience here or from online.
Yeah, for patients who had a good response on nivolumab and now on maintenance for more than 2 years, some patients ask me, they want to discontinue it. They didn't have any side effect, just they are traveling from long travel to take the medications and back. I'm against that totally. Any other recommendation for this patient, or just we have to continue?
I think the recommendation is to continue. Okay, so I'm not sure stopping is a good idea, but from the immunotherapy trials, we know even this trial, even those patients who stop the treatment, their survival is comparatively better. So they usually do well even after stopping the treatment, but not for the reason because the patient do not want, or if there's any other reason. If they can continue, we would prefer. But for any reason you stop it, mostly it's the toxicity where you stop it. Yeah. Even those patients do very well actually in terms of survival. So personally, I have few patients, and I haven't come across this sort of scenario where the patient is asking to stop the treatment. All I did, there were a few patients who said, I cannot come every 2 weeks. And especially in COVID, we changed it to almost everybody now is getting once a month treatment. And they're usually okay. They come, it's only a matter of 1.5 hours or so, and then they go home.
Thank you.
Okay, so our next speaker is Dr. Issam Murshid, who is the chairman of the meeting also. He will be talking about I'll share the session with the Dr. Bassam also. Yes, yeah, 2 speakers. So they both will be talking about the metastatic castrate-resistant prostate cancer, which is one of the very evolving topic and a lot of controversies. Sequencing is one of the things, how to sequence. I hope we will learn from their experience.
Thank you, Faisal. It was a very interesting, as usual, presentation. You didn't leave much for question, except if Fahad was here, then he will start discussing with you. Thank you very much for the sponsor of this satellite symposium, Stellis. And without any further ado, I'm going to introduce my colleague, Dr. Bassam Basliman. Bassam is a consultant medical oncologist at King Fahad Medical City Comprehensive Cancer Center with the special interest of GI and GU tumors. And he's going to speak about the recent advances in the management of metastatic castration-resistant prostate cancer. Bassam, the floor is yours, and you have, I think, 20 minutes, sir. Thank you.
Thank you, Dr. Murshid, Sam Murshid, for this introduction. And I would like also to thank the organizing committee and Stellis for sponsors for this satellite symposium. I'm supposed to talk about the recent advances in management of metastatic castrate-resistant prostate cancer. So this is my disclosure. So I will start here with this slide. I will start with the historical perspective with regard of original seminal observation by Charles Huggins. It's demonstrating that prostate cancer is androgen-driven dependent disease, and surgical or medical castration can induce significant regression in prostate cancer. Which is published in 1941, which actually means around 80 years now ago. Still the androgen deprivation therapy is the mainstay treatment for prostate cancer. Also, it was reported at that time that acid phosphatase as a biomarker, which I think was one of the first biomarker known in malignancies. Also, so we know that more than 90% of the patient initially responds to androgen deprivation therapy. However, most will progress to castrate resistant with a median overall survival around 4 to 5 years. And this data, depending on, including the recent advances in the metastatic hormone sensitive prostate cancer, and now I think reached with the BEAST trial recently to 6 years. So progression to castrate resistant, it's because the androgen dependent signaling mediated prostate cancer growth despite castration level on the serum testosterone. And mechanism of that is not that clear, but there is multiple theory. One of them is receptor overexpression, amplification, androgen receptor mutation, hypersensitivity, increase in the androgen receptor ligand synthesis, androgen receptor coactivator, and CHIP response. So before 15 years, the construction was one part of the disease with developing a lot of options. And now we are moving to this developing management was moved to earlier the disease stage. So we can see here that in yellow squares, the disease stages that associated with castrate-resistant disease, we have non-metastatic and metastatic. And I will concentrate in my talk about the metastatic castrate-resistant prostate cancer in first line or further. In metastatic castrate-resistant prostate cancer, we have multiple agents has been shown improve overall survival in phase 3 trials, and all was given in conjunction with the continued androgen deprivation therapy. And the first milestone in metastatic castrate-resistant prostate cancer was in 2004 with using the docetaxel, which show overall survival at that time when compared to metaxantrone. And then we have a pause for around 5 years. And in 2010, we have the cabazitaxel and spiloCLT. And then we enter the era of novel androgen therapy, the abiraterone and enzalutamide in 2011 and 2012. After that, the radium in 2013. And then we have another pause for around 3 or 4 years. And we enter the precision medicine with using pembrolizumab and the MSI high, olaparib and rocaparib, and DNA repair alteration, and PSMA positive patient with these using the lutetium PSMA in 2021. So just in a few slides, I will review the data that we have in metastatic castrate-resistant. And the first line treatment before we have the milestone for management of castrate-resistant prostate cancer is docetaxel in 2004 with the first 3 trial, TAX 3327, which is comparing docetaxel with prednisolone versus metoxantrone with prednisolone, and which showed significant overall survival. And based on this result, docetaxel plus prednisolone has become the standard. The second, we have the abiraterone with prednisolone in the first line pre-docetaxel was assessed in a phase 3 trial in patients mainly asymptomatic or minimally symptomatic with no visceral metastasis. And the result of this data showed there is improvement in overall survival once compared abiraterone with prednisolone versus placebo with prednisolone. And the third is spiloCL in the same year, which is assessed in a phase 3 impact clinical trial in patients who had minimal symptoms with no visceral metastasis, comparing spiloCLT versus placebo. spiloCLT is actually limited access. It's only in limited center in the US and not available worldwide. And once assessed in this type of population who had minimal symptom It showed there is improvement in overall survival, but interestingly, there is no significant increase in progression-free survival or effect on the PSA, which is make the assessing of efficacy an impact on this patient will be difficult. Came to the Radium 223 assist in phase 3 trial in patients including pre-docetaxel and post-docetaxel and SAMPACA clinical trial, or assessing a patient who had symptomatic bone metastasis with either Radium 223 versus placebo. And here it's shown an overall survival and improvement in skeletal-related event. And lastly, on the first line, we have the enzalutamab in 2014, a PREVAIL trial, was assessing, including patients who had metastatic castrate-resistant, chemo-naive, either have visceral metastasis or not. And in the first interim analysis, the data was stopped because the result was significant, improving the overall survival for the enzalutamab arm versus placebo, and they have to stop the trial, but the result was significant for overall survival and radiological progression-free survival. And recently, we have the latest analysis with greater than 5 years follow-up, and the median overall survival for these patients who had enzalutamab is maintained with persistent for a median overall survival of 36 months versus 31 months for the placebo arm, and hazard ratio 0.83. So once we are comparing these trials in the first line, we know the docetaxel is the standard we have. They include all the patients, regardless of visceral metastasis, symptomatic, non-symptomatic, who had castrate-resistant prostate cancer. But the other agent was on assessed in clinical trial. They have specific inclusion criteria. So we can see the abiraterone they exclude patients who had symptoms of visceral metastasis. For the PREVAIL trial and enzalutamab, they exclude patients who had symptoms. But in the Radium, they exclude patients who had visceral metastasis. Sorry, they exclude patients who had visceral metastasis and asymptomatic. So include only the bony lesions and symptomatic. Symblucil, as the abiraterone, they exclude the symptomatic and visceral metastasis. So this conclusion is important. This inclusion criteria is important once we are assessing these results. So specifically for PREVAIL trial, once assessing the enzalutamide, we can see the benefit is still continued regardless of the disease status, is it visceral metastasis or not. So we can see the radiological progression-free survival is maintained. We can see the result of positive for visceral disease and also overall survival. Going for post-docetaxel in the second line, we have multiple agents approved. In 2010, we have cabazitaxel, assist in TROPIC clinical trial, comparing cabazitaxel versus metoxantrone with prednisolone, and it's shown there is improvement in overall survival and progression-free survival. So once we have the cabazitaxel approved and there is efficacy in castrate-resistant, was assessed in the first line, we compared to docetaxel, cabazitaxel versus docetaxel, and Firstana trial, and the results show there is no difference between the cabazitaxel and docetaxel in the first line castrate-resistant prostate cancer. But interestingly, the toxicity of cabazitaxel is better or less than docetaxel in terms of febrile neutropenia, in terms of peripheral neuropathy, and alopecia and nail disorders, especially for the patient who had a lower dose, the 25 milligram per meter square every 3 weeks. Going to the other agent in the second line, we have the abiraterone with prednisolone, assist in patient who had progressed on docetaxel in phase 3 trial, KOU 302 trial, which show positive for overall survival and progression-free survival. Also, the enzalutamide and AFFIRM trial assist in patient who progressed on docetaxel, comparing enzalutamide versus placebo, and the same as the PREVAIL, the study was based on the result of the blind interim analysis. The blind was broken because the patient allowed to cross over from placebo to enzalutamide upon progression. This result because the overall survival was significantly increased with enzalutamide compared to placebo, with a median 18-month versus 13-month, with hazard ratio 0.63. And the radio, as I mentioned before, is once they include patient who had progressed also on docetaxel. So in this slide, I would like to mention the most important special profile for these medication that I explained now. And we can see here, we have our patient should be considered once we are using this side effect. The most important in this slide about the interaction for enzalutamide and abiraterone, we have to review once prescribing these medications with our clinical pharmacist to be sure there is no interaction with these medications. So what about third line? This is the recent updates that we know that in the last 3 years, we should try our best that during the course of disease to fit the patient to receive one of the novel endocrine therapy agent and docetaxel. But in 2019, we don't know after these two medication, what's the best is to use switch to another novel androgen inhibitor or to use the cytotoxic. And here the CAR trial came in 2019 or 2020, which presented in New England 2019. They include patients who had progressed on docetaxel, receive at least 3 cycles, and receive disease progression on abiraterone and enzalutamide for less than 12 months. And they randomized the patient to cabazitaxel with prednisolone versus enzalutamide or abiraterone with prednisolone. And the primary endpoint was the image-based progression-free survival. The primary endpoint was met in this trial. As we can see, the median progression-free survival was getting better by around 4.3 months, and the hazard ratio is 0.54. Also, the overall survival is better, as the median we can see here is getting better by 3.6 months, and the hazard ratio 0.64. Not only the progression-free survival and overall survival, one of the important secondary endpoint is the pain response. We can see in these patients specifically after 2 lines of systemic therapy, and now we are on the 3rd line, the chemotherapy, cabazitaxel, compared to the novel androgen therapy, has a better responding the pain, 45% versus 20%, which is important endpoint for me. Now going for the precision medicine in prostate cancer, it's three target pathway I would like to discuss it. The first one is the MSI high or MMR deficient patient with metastatic castrate-resistant prostate cancer. We can use an option of pembrolizumab. The FDA had accelerated approval for pembrolizumab as a first tissue site agnostic indication. And we have a case report that it had pembrolizumab show efficacy in these patients who had MSI high. And the percentage of patients with prostate cancer who had MSI high is very small, is representing 2 to 3%. What about PARP inhibitor on prostate cancers? The DNA repair gene alteration are common in metastatic cancer. It represents around 23% in metastatic CRPC who had DNA repair alteration. And the frequency of DNA RNA alteration increased with disease progression. Regarding the germline, which can be done from the blood, it's representing only 12%. So it's recommended to be done this germline and somatic for this patient. And the right diagram, I would like here to be shown that the most common DNA repair gene alteration we are seeing in castrate-resistant prostate cancer is the BRCA2, which represents around 44%. PROFOUND trial showed the efficacy of PARP inhibitor in castrate-resistant prostate cancer. So they include patients who had metastatic CRPC, who progressed on a novel new hormonal therapies, and had gene alteration in the homologous recombination repair. And they dividing the patient to cohort A and B, cohort A including the BRCA1, 2, and ATM alteration, and the other alteration of DNA repair alteration, they included in cohort B. And they randomized the patient 2 to 1, either olaparib or physician's choice. The physician's choice is mainly for enzalutamide or abiraterone, and they allowed for crossover once the patient had disease progression. It's important here to mention that the screened patient is around 4,400, and the successfully sequenced is around 69%. And 28 of these patients has qualifying mutation. And for patient, most of the patient here included in the trial, some patient, 20% of the patient, it's using enzalutamide and abiraterone in previous lines. And one of the things also important that 35% of the patient not receiving chemo at all. So they receive only a novel androgen hormonal therapy. The primary endpoint, which was the radiographic progression-free survival in the cohort A, and we can see here clearly the separation of the curve with the difference in the progression-free survival by around 4 months or 3.5 months, and the hazard ratio 0.34. The overall survival, there is a difference in the median for around 5 months, and the hazard ratio 0.69. And remember, they allow for crossover, and 66% of the patient on biopsy and the patient physician's choice, it's crossed to be receiving olaparib. And once we had cross-analysis and cross-adjusted analysis, the hazard ratio will be 0.55 here. So olaparib has approved in May 2020, depending on this data, for patients who had castrate-resistant prostate cancer with the HRRG mutation, who had progressed on prior enzalutamide or abiraterone. The other PARP inhibitor is the Triton rucaparib, was assisted Triton, which is a phase 2 multi-center trial, including patients who had progressed on chemo and the novel androgen inhibitor. And the result of this phase 2 trial showed that, as you can see here from the waterfall plot, is clearly that the rucaparib has efficacy in this patient. 44% of the patient has objective response. So depending on that, the rucaparib was approved by FDA in the same month for patients who had BRCA mutation, castrate-resistant prostate cancer, and has previously treated with docetaxel and androgen deprivation therapy. And we are waiting for the Triton 3, which is a phase 3 comparing rucaparib versus the physician choice. Interestingly here, the physician choice, it will be including the docetaxel and the enzalutamide and abiraterone. And the population that will be included in the trial, patients who only progressed on novel androgen inhibitors. So we're waiting for this data for the rucaparib. And as discussed by Dr. Abdulrahim today, and Dr. Abdulrahim Shangid and Dr. Mark, they explained in detail the role of the lutetium PSMA and the castrate-resistant prostate cancer. So I will skip this just to avoid repeating. And it's presented, it showed the result is significant improvement in overall survival and progression-free survival in the VISION trial. So I will skip that. So, as you can see, we have several agents approved for metastatic castrate-resistant prostate cancers, but the optimal sequencing is unclear. None of these metastatic castrate-resistant prostate cancer trial compare the new agent with the current real-world standard of therapy. The current real-world standard of therapy, we are using combination the hormonal sensitive, either using the abiraterone or enzalutamide or docetaxel with the androgen deprivation therapy. So it's difficult to assess the sequence, what optimal can be used in the castrate-resistant setting. So the factor that help treatment decision during for choosing which one of these is the patient history, symptom or non-symptomatic, co-medication, comorbidities, clinical exam, what the patient received in the castrate-sensitive setting, how's the response in the first setting, the staging workup, including the germline and somatic mutations to assess if there is DNA alteration, PSMA, and the MSI or mismatch repair deficient. And lastly, it's important to check the patient preference. The decision here, and at this point, I think it's a shared decision making between the clinician and the patient. So in conclusion, Overall survival for metastatic castrate-resistant prostate cancer has tripled in the past 20 years. Individual agent each produce a modest absolute improvement in median overall survival. Several survival prolonged treatment option in metastatic CRPC. The optimal sequencing is still unclear and complex with advent of a combination therapy for metastatic castrate-sensitive prostate cancer. Cabazitaxel has overall survival benefit as a third-line treatment in patients who received docetaxel and also novel endocrine therapy. Germline and tumor genetic testing inform the selection of patient with mCRPC for treatment with PARP inhibitor. And as recently data, the 177 lutetium PSMA 617 is the new treatment option in patients with metastatic CRPC, previously treated with the novel androgen receptor inhibitor and taxane therapy. And thank you for your attention.
Thank you, Bassam. You took 5 seconds extra. Thank you very much for the very nice and comprehensive review. Do we have any questions from the floor or online? Okay, Dr. Azam.
Thank you, Bassam. It was excellent, actually. The question, probably we don't know the answer for it, which is about sequencing. If you have a patient you've treated with new hormonal agents in metastatic hormone sensitive, and the patient is HRR mutant, when they become castrate resistant, would you give PARP inhibitor at that time, or would you like to give chemotherapy? And then you can have an option of giving lutetium at that time. Or you would straight away go to olaparib or PARP inhibitor. And if you start olaparib or PARP inhibitor, for how long will you give that?
Yeah, that's a good question. Thank you. Our patient usually they are elderly, have comorbidities, and we are trying to avoid chemotherapy to be used in them. In the PROfound trial, there is a good number of patients is 80 years old and have comorbidities, and I think olaparib is a safe medication. So it's an option, can be used before docetaxel and this setting, and I will consider it if there is patient asymptomatic, only PSA progressing asymptomatic. But if patient symptomatic and I want a rapid response or I want a response, I will go with docetaxel.
Thank you.
Okay, if there is no more questions, thank you very much. Dr. Bassam, Dr. Faisal, and the guys for honoring us with your attendance today and presentations, which was marvelous as usual. And we are closing the session now. We'll take a group photo for everybody around for the session, and then one after the last session. So everybody, please come forward.
Hello.
Hello, Professor.
Hi.
I'm Dr. Kandil.
Hi, Sylvie Lorenzen. I'm the discussant of the 5 abstracts or
Yes,
4 abstracts.
yes, you're most welcome.
Thank you very much. Thank you.
We are waiting till they allow us to start.
Of course. I think we start in 5 minutes, right?
Yes.
Okay. So I mute myself and during the discussions, during the presentations, and I just unmute and show the picture, the video when I discuss. Is this right?
Yes, and then there will be panel discussion at the end of the presentation.
Absolutely. But during the presentations of the abstracts, I will mute myself and also close the video, right?
Yes, yes. Everyone will except the one who is presenting. Thank
Cool.
you. Thank you.
السلام عليكم، مساء الخير دكتور مجدي. هاي دكتور سيلفيا.
اهلا وسهلا.
When do we start?
Maybe 5 minutes because they are doing prayer. So they are.
Oh, I see.
5 minutes. I'm calling them.
السلام عليكم.
عليكم السلام دكتورة ميرفت.
First of all, I would like to thank you again for attending the second day, and we are so appreciating all attendees from different regions, and we have very distinguished speakers. It's my pleasure to introduce the fourth session and the last but not least session with the GI session, and we do have a greatest panelist for the session. First of all, I would like to introduce our dearest professor, Professor Magdi Qandil. Dr. Magdi Qandil, he is professor in clinical oncology in Cairo University, Qasr Aini. And we do have Dr. Omar Al-Shaar. He is a medical oncology consultant in the Armed Force Hospital. And we do have as well Dr. Iman Bukhari. She is a palliative care consultant, and she is the head of the quality team. And Dr. Huda Mukhtar, she is medical oncology consultant in Prince Sultan Military Hospital. I will convey the message to our panelists. Thank you very much for attending.
Thank you, Dr. Mervet, for your kind introduction. I would like to thank Dr. Issam Murshid and Dr. Abdulaziz Al-Hamad and Dr. Mervet Mahrouz for their kind invitation. I want to congratulate you all for this great meeting. We'll start this session with Dr. Muhammad Al-Garni, who is a consultant medical oncologist and a colleague. He's section head of cancer control and outreach program at King Abdulaziz Medical City. He will present the updates of the expanded efficacy analyses of Checkmate 577 for adjuvant nivolumab in resected esophageal or GEG cancer following neoadjuvant chemoradiation. Go ahead, Dr. Garni.
Thank you very much, Prof. Majdi, for the kind introduction. And I would like to thank the organizing committee for the kind invitation to present the Checkmate 577 study, the expanded efficacy and quality of life analysis. So basically this study, which studied the adjuvant nivolumab in resected esophageal or gastroesophageal junction cancer following neoadjuvant chemo radiotherapy, initially was presented last year in ESMO 2020, and this is the expanded efficacy and safety analysis of this study. So as a background of this study, the patient with resectable locally advanced esophageal cancer or gastroesophageal junction tumor, neoadjuvant chemoradiation followed by surgery, which is known also as trimodality therapy, is a well-established one of a standard of care for such patients. The risk of recurrence following this tri-modality therapy remains high, particularly if there is a residual pathological disease. However, we don't have established adjuvant treatment for those patients prior to this study. So the CheckMate 577 was the first global phase 3 randomized double-blinded study to evaluate the immune checkpoint inhibitor in the adjuvant setting following the tri-modality therapy. In this study, nivolumab demonstrated statistically significant and clinically meaningful improvement in disease-free survival versus placebo, and was well tolerated with an acceptable side effect. This study was published in New England Journal of Medicine, 1st of April 2020. And in this presentation, we'll go over the recent update on the efficacy and quality of life. So this is the design of the CheckMate 577. The included patient with a stage 2 and 3 esophageal or gastroesophageal junction tumor. Both histology, adeno, and squamous were involved. Patients treated with new adjuvant chemoradiation followed by R0 surgical resection, and this performed within 4 to 6 weeks prior to the randomization. Residual pathological disease, whether T1 or higher, N1 or higher, and the patient has good performance status. The stratification was based on the histology, the pathological lymph node status, and the tumor PD-L1 expression. The median follow-up for those patients was 24.4 months. They randomized 794 patients in a 2-to-1 ratio. 532 patients treated with nivolumab and 262 patients with placebo. The primary endpoint of the study was the disease-free survival. The secondary endpoints was the overall survival. The exploratory endpoint included safety, distant metastasis-free survival, progression-free survival 2, and quality of life. So this is the baseline characteristic, which was balanced between the two treatment group. As you can see here, most of the patients, they have ECOG 0 to 1. Majority of patients have stage 3. As you would expect, 2/3 of the patient, they have adenocarcinoma and 1/3 squamous cell carcinoma. And the tumor PD-L1 expression more than 1% was 17% in the nivolumab arm and 15% in the placebo arm. They did a post hoc analysis for the baseline PD-L1 CPS 5 or higher, and they observed that 57% of patients in nivolumab arm has PD-L1 CPS 5 or higher, and it was balanced with the placebo arm, which was 54%. So this is the initial analysis of the study that showed clear superiority of nivolumab over placebo. The hazard ratio was 0.69, and the nivolumab provided superior disease-free survival with equation to 31% reduction in the risk of recurrence or death, and doubling of disease-free survival versus placebo. When you look to the disease-free survival subgroup analysis, again, it was in favor of patients treated with nivolumab. In the subgroup analysis, they include the histological type. There might be a signal for better benefit for the squamous cell histology. Both tumor PD-L1 expression more than 1 or less than 1% benefit from the nivolumab. The pathological lymph node status, pathological tumor status, and the time from complete resection, all these was in favor of a patient treated with nivolumab. Now, this is the new updated efficacy signal, which studied the distant metastasis-free survival, which is defined as the time between a randomization and the first distant recurrence or death, whichever occurs first. As you can see here, also was in favor of nivolumab, and it showed 26% reduction in the risk of distance recurrence or death versus the placebo. Another efficacy endpoint, which was the progression-free survival 2,
which is defined as the time from a randomization to progression after the first subsequent systemic therapy, initiation of second subsequent therapy, or death, whichever came first. And also it showed superiority of nivolumab with a hazard ratio of 0.77, and the median progression-free survival for nivolumab was not reached. Now, what about the safety? Nivolumab was well tolerated, and the majority of the treatment-related adverse events were grade 1 or 2. If you look to the serious treatment-related adverse event was about 8% in nivolumab arm versus 3% in the placebo arm, and the treatment-related adverse event that is led to discontinuation of therapy were 9% in patients with nivo versus 3% in the placebo arm. Now, looking to the adverse event that has potential immunological etiology, again, most of them, they were grade 1 or 2, grade 3 to 4 occur in less than 1% of the patient, and there were no grade 5 select treatment-related adverse event. What about the onset and the resolution of the treatment-related adverse event with potential immunological etiology? Most of the patients who develop the treatment-related adverse event with potential immunological etiology have recovered and treated with the established management algorithm. The median time for symptoms or the side effect to happen was 6 to 13 weeks, and the median time to resolve was 3 to 21 weeks. Looking to the quality of life, this is the FACT-E-GPS, which is a cancer-specific measure that captures patient quality of life. And majority of patients were not at all or a little bit bothered by the treatment side effect in both treatment arms, and the proportion of patients was not bothered by side effect were similar in both treatment arms. Also, looking to another quality of life measure, the patients who were in treatment, they showed trend in a better quality of life during the treatment and on the follow-up in both treatment arms. And again, this is the esophageal cancer subscale, which showed improvement in both arms while on treatment and maintenance of quality of life after treatment was stopped. So the summary of the study by the author that adjuvant nivolumab demonstrated clinically meaningful efficacy in patients with resected esophageal cancer or gastroesophageal junction following neoadjuvant chemoradiation compared to placebo, 31% reduction in the risk of recurrence or death, and doubling in median disease-free survival. The disease-free survival benefit was noticed across different subgroups, and less frequent distance and local regional recurrence in the nivolumab arm, and improvement in the disease metastasis-free survival and progression-free survival. Adjuvant nivolumab demonstrate an acceptable safety profile and maintained quality of life. And these results provide further support for adjuvant nivolumab as a new standard of care for patients with resected esophageal or gastroesophageal who receive neoadjuvant chemoradiation with residual pathological disease. And based on this study, the FDA granted approval for nivolumab in this clinical indication. And by this, I conclude, and thank you very much.
Thank you, Dr. El-Garni, for your presentation. Now we'll go for the next speaker, our panelist, Dr. Abdullah Sharm. He's our dearest colleague and Director of Cancer Center at King Fahd Medical City. And he's one of the figures of GI and Gynecology in Saudi Arabia. And he will present the next speaker.
Thank you. Thank you so much, Military Hospital. Dr. Walid Al-Salawi, he is a consultant GI oncologist in King Fahd Specialist Hospital, Dammam. is going to speak about pembrolizumab and trastuzumab in patients with HER2 positive metastatic gastric cancers. So Dr. Walid.
Thank you, Dr. Prof. Abdullah Sharm. Thank you for Dr. Majdi and all panelists. And thank you to Dr. Morshid and Dr. Mervat to arrange such excellent and proud meetings. And thank you for invitations. I start, this is my presentation, this abstract of the ASCO. This is very quick introductions as age standard for the gastric cancer in 2018 and over 1 million new cases in 2018. And most of those is the 5th most common cause of malignancy and is the 3rd leading cause of cancer death. Between 40 and 80% of the patients with the gastric cancer patients have metastatic disease at diagnosis. As this slide shows, the biological difference among the tumors type just show how is we are, and the most of those targeted field in development and genomic dissection of the gastric did not translate to the clinical practice. And those shows how is the difference between the genomic dependency. Also, as you know, there is a heterogeneity of the disease from the morphological side and from the genetic side. And this is how is that present in the first line of treatment based on the molecular classification of the HER2, and around of 18 to 20% of metastatic gastric cancer have HER2 positive. And those is chemotherapy and trastuzumab based. As you know, this is the first study, only just very quick update, shows that the first study shows efficacy of the trastuzumab in gastric cancer and shows those patients with HER2 positive designed to the trial, and then shows there is overall survival benefit that is in 2004, and also progression-free survival, and also based on the FISH and H2 and immunohistochemistry shows also overall survival versus, and then they become the standard cancer. Then now in 2021, immunotherapy, adding immunotherapy to the trastuzumab chemotherapy the benefit. This is the presented in the ASCO 2019, shows that added of the pembrolizumab to trastuzumab and chemotherapy shows that overall that is very objective response rate. And this is in this year in June 2021, the Keynote 811 first line pembrolizumab trastuzumab with chemotherapy in HER2 positive metastatic gastric or gastroesophageal junction cancer. Again, this is the background of trastuzumab with chemotherapy, fluoropyrimidine-based chemotherapy, first standard care of chemotherapy in patients with HER2 positive metastatic gastric cancer or gastroesophageal junction cancer. It is the phase 2 shows there is pembrolizumab, trastuzumab have meaningful activity and anti-tumor activity in this setting. And also the Keynote 811 trials is evaluating the safety and efficacy of adding pembro to trastuzumab and chemotherapy in the unresectable metastatic gastric cancer HER2 positive. And presented there is a protocol of those specified therapy, and this is presented in the June this year, and shows this is the scheme and the trial, you know, the phase 2 show overall and 100% of the response and progression-free survival, 80% of the patients, and about 80% of the patients have 12 months overall survival. And this is based on the bunting trials in the presented in 2019, the ASCO. And again, this is the patient characteristic adenocarcinoma, no prior therapy, with advanced setting with HER2 positive disease, stratified according to the geographical region and BDL1 and CBS and chemotherapy choice. There is a pembrolizumab 200 milligram IV Q3 weeks, and trastuzumab and chemotherapy KBOX or 5U based chemotherapy for up to 35 cycles, and placebo arm trastuzumab and chemotherapy for up to 8.5 months, and dual primary endpoint overall survival and progression-free survival, secondary endpoint overall response rate, and safety and disease overall response. This is the protocol specified first interim analysis, shows the timing to occur with first 260 patients participate in enroll and more than 8.5 months for follow-up, objective to assess whether the adding pembrolizumab to trastuzumab chemotherapy significantly improve overall response rate and superiority boundaries with progression with p-value 0.02. Also, the data cutoff was June 17, 2020. The patient is participate in this study is around 434. Efficacy population first is 264, and follow-up of the median 12 months with a range of 8.9 is 19.4 months. And there is in the pembro arm is 40% and placebo arm 28%. With safety population, 433 participants who received more than one dose of study medications, and follow-up of duration median 9.9 months with a range of 0.1 is 19.4 months. And in the continuity of the arm of the study, pembro is 58% and 48% in placebo arm. The basic characteristic of the patients is
2 minutes, please.
Okay, it is the age, sex, and the primary diffuse type, and PDL1 in the both arms, and HER2 status. Also, the chemotherapy base of chemotherapy. Again, this shows the analytical analysis of the overall response rate with patient with the pembrolizumab is 74% compared with 55% in the placebo arm. And again, this is the curve shows curve that is the waterfall curve shows is that the response is about 75 in the pembro arms and around of 50% in patient with chemotherapy arm, with overall response rate both is very significantly with patient adding the pembrolizumab with CR 15% in the pembro arm and 4% in placebo arm. Partial response 80% in the pembro and 44% in the placebo arm. Again, this is the adverse event shows there is usually there is no more than usual for a safety profile with immune mediated also with any grade 34 in the pembrolizumab arm, 21 in the placebo arm, and also the incidence of the more than 2% in the 18% of the infusion reaction compared with the 1% in the grade 3 to 4. From summary of the keynote 811, pembrolizumab plus trastuzumab and chemotherapy provide 74 overall response rate that result in statistical significant clinical meaningful 22.4 improvement in overall response rate and improved with placebo plus trastuzumab and chemotherapy. And response to the pembro plus chemotherapy plus trastuzumab were deeper and more durable. And adverse event was similar between both arms, with observed a side effect was expected to with no new safety concern identified. A study is continue as planned as analysis overall survival and progression-free survival will be performed in the future according with analysis plan. And this is the cue of this study. Pembrolizumab plus trastuzumab and chemotherapy is potentially a new standard options for previously untreated, unresectable, or metastasis HER2 positive gastric or gastroesophageal cancer. This is the same message for a patient with HER2 positive gastric cancer. Thank you.
Thank you, Dr. Walid. We'll go with the third speaker, Dr. Samah Al-Ruhaili. And I think who's Dr. Samah Al-Ruhaili, she is going to present a trial about liposomal irinotecan in combination with Vivu and leucovorin in patient with metastatic biliary tract cancer after a progression of gemcitabine plus cisplatin. It's called NIFTY trial. So Dr. Samah Harwaili, she's a consultant in National Guard Hospital in Jeddah. So Dr. Samah, the mic for you. So Dr. Samah. So let's go with Dr. Kanaan al-Shamri until Dr. Samah join us. Dr. Samah. So Dr. Kanaan al-Shamri, he's beyond any introductions. He's a consultant, GI, oncologist, National Guard again. I don't know why Dr. Merfet chose all the people from National Guard. From National Guard Hospital, and this is the expert people, of course. National Guard Hospital in Riyadh. He's going to present a very important clinical trial about folfoxiri plus cetuximab versus folfoxiri plus bevacizumab in first-line treatment of metastatic colorectal cancer. It's JACOR CC 13 trials. So Dr. Kanaan.
Introduction. And I also would like to thank the organizers for asking me to talk about the DEEPER trial. So without further ado, the DEEPER trial was a randomized phase 2 study of folfoxiri plus cetuximab versus folfoxiri plus bevacizumab as first-line therapy for metastatic colorectal cancer with RAS wild-type tumor. And this was presented in the most latest ASCO. So as a background, triplet regimens, so folfoxiri combined with Avastin or panitumumab, have been shown to be superior with regards to early tumor shrinkage and depth of response compared with doublet regimens plus Avastin or triplet regimens in patients with RAS wild-type metastatic colorectal cancer. TRIBE trial and VOLFI trial have shown that when you add a biologic on top of folfoxiri, that you will get superior outcomes. Now, there have been very few studies which compare cetuximab and Avastin when combined with the triplet regimen, and hence the study. So the objective of the study was to actually compare folfoxiri plus cetuximab against bevacizumab as a first-line therapy in RAS wild-type metastatic colorectal cancer. Now, the primary endpoint was carefully chosen to be the depth of response during the entire course. Other secondary endpoints were objective response rate, early tumor shrinkage rate at 8 weeks, progression-free survival, and overall survival, as well as R0 resection rate. So what is depth of response definition? I think it's important before we proceed to actually spend some time talking about this. So depth of response is the percentage of tumor shrinkage based on the longest diameters or reconstructed volume at the smallest observed volume compared with baseline. It basically means the maximal tumor shrinkage that ever happened. And it's basically a continuous measure as opposed to early tumor shrinkage, which is taken at one specific time point. So methods, so this was a randomized trial, randomizing into 2 arms. The first arm is folfoxiri plus cetuximab, given for 12 cycles, followed by maintenance of 5-FU leucovorin and cetuximab combination. So dropping the irinotecan and oxaliplatinum, compared with folfoxiri plus Avastin for 12 cycles, followed by the same. So who were eligible? So basically all confirmed histologically colorectal adenocarcinoma that were RAS wild type, that were advanced or metastatic or recurrent, that had measurable disease and performance status of 0 to 1. And if patients were elderly or above 70, they have to have a performance status of 0. So just basic statistics, the experimental arm would be effectively or would be active if the difference in depth of response was over 12.5% compared with the Avastin arm. So the consort diagram, basically almost 360 patients were randomized, almost 180 to folfoxiri and bevacizumab, and 179 with folfoxiri and cetuximab. Now, the full analysis set included 175 patients in each arm, However, there were unevaluable patients, and hence we were left with the per protocol set, which was 158 in the Cetax arm and 162 in the Avastin arm. So just as a general patient characteristics, I want you to pay note that 80% of those patients were actually left-sided tumors. Very minimal of them had adjuvant chemotherapy, and most of them were actually de novo metastatic disease. Now, again, most of these patients, so more than 90%, were actually ECOG performance 0. So these were super fit patients. With regards to metastatic deposits, it's important to note that in the cetuximab arm, more patients had peritoneal disease, so 20% versus 15%, and more patients had ascites, so 10% as opposed to 3.5%. Now, with regards to treatment courses or reasons for discontinuation, most patients discontinued because of progressive disease. Some discontinued because of surgical resection. And 4 patients in the cetuximab arm discontinued because of complete response, as opposed to 1 patient in the Avastin arm because of CR. With regards to depth of response, now this is the primary endpoint. Basically, for the folfoxiri cetuximab arm, this was 57.4%, as opposed to 46% in the Avastin arm, and this was statistically significant. And the study was actually measured or assessed to measure depth of response. Now, the waterfall plot was quite impressive. You can see most patients actually responded. The purple waterfall diagram is the Avastin arm, and the orange one is the cetuximab arm. And you can see the cetuximab exceeding the Avastin with regards to the depth of response. Now, let's pay attention to this table because that's important. So if we actually divide patients up into left versus right-sided, the left-sided tumors with regards to depth of response had a superior outcomes compared to the Avastin. So cetuximab was 60% as opposed to 46% in the Avastin arm. And it was still superior in the right-sided tumors. However, the difference was much less. So it was 50% depth of response, 1% for the Avastin. Now, in the right-sided, the difference was not statistically significant. However, it was strongly statistically significant for the left-sided. With regards to overall response rate, so 11 patients had CR in the Cetux arm, as opposed to 4 patients having CR in the Avastin arm. When we actually combine the overall response rate, so that's your partial responders and your complete responders, it comes to 69% as opposed to 71% for the Avastin arm, not statistically significant. DCR was favoring Avastin arm at 95% as opposed to 90%. However, this was not statistically significant. Early tumor shrinkage, this was a secondary outcome, was favoring the cetuximab arm at 77% as opposed to 74% for the Avastin arm. However, the difference was not statistically significant. Our 0 resection rate was actually favoring the Avastin arm, however, not statistically significant. With regards to toxicity, expectedly with anti-EGFR monoclonal antibodies, we do see more rashes, more skin toxicity, and more hypomagnesemia. And with anti-VEGF, so Avastin, we expect more hypertension, more bleeding, and probably more thromboembolic events. Now, this is all comers. So the full analysis set, PFS, was an impressive 12.7 months. Now, remember, this was triplet plus a biologic. Overall response rate was also an impressive 37.6 months for the whole comers. Now, the author's conclusion was that folfoxiri plus cetuximab is significantly superior to folfoxiri plus Avastin with regards to the depth of response as the primary endpoint in first-line treatment for RAS wild-type metastatic colorectal cancer. Now, my humble conclusions is that there is a wealth of evidence supporting cetuximab and chemotherapy for left-sided metastatic colorectal cancer in the first-line setting. It can be used for with triplet chemotherapy with superior depth of response, as we have shown in the deeper trial, However, we still need to pay attention that more than 80% of these patients had left-sided primaries, and more than 90% of those patients were actually ECOG performance status of 0. Now, it's also important for us as treating medical oncologists to consider the goal of therapy prior to choosing to actually get the patient to go for radical resection. So early tumor shrinkage or depth of response is needed here. Then we would consider triplet chemotherapy backbone plus a biologic. And by that, I conclude. Thank you.
Thank you, Dr. Kanaan, for your presentation. Now, Dr. Omar Al-Shair, he's a consultant medical oncologist at Security Forces Hospital and colleague. He will present the next speaker.
Thank you, Prof. Majdi. First of all, thank you, Dr. Mirfat, Dr. Marshad, Dr. Abdulaziz Al-Hamad, to give me this chance to introduce my colleague, Dr. Samah Ruhaili from National Guard Hospital, Jeddah. She will talk about NIFTY multi-center comparative randomized phase 2 study. Welcome, Dr. Samah.
Assalamu alaikum. Can you hear me now?
Yes, Dr. Samah.
Okay, perfect. So, can you see my slide?
Share screen, Doctor, please.
Okay. Can you see my slide now?
Yes.
Okay, perfect. Assalamu alaikum. Today I would like to thank the organizing committee for giving me the chance to present today. And today, inshallah, I will be talking about the NIFTY study, which was presented by Dr. Yu in ASCO 2021. And it's about the liposomal irinotecan in the combination with 5-fluorouracil and leucovorin for patients with metastatic biliary tract cancer after progression on GemCis. It was a multi-center comparative randomized phase 2b study, and it was in Korean centers. So GemCis is the standard first-line chemotherapy for patients with unresectable or metastatic biliary tract cancer. For patients progressed on GemCis, there was no globally established second-line chemotherapy. However, the fluoropyrimidine-based therapy has been widely used in daily practice, despite lack of data based on the randomized trial. Although the VEGFR and IDH1 inhibitors have demonstrated clinical benefits in the BTC patients harboring the VEGFR2 gene fusion or IDH1 mutations, only up to 20% of patients could benefit with these targeted agents. Recently, the ABC06 trial demonstrated the survival benefit of second-line FOLFOX compared with the active symptoms control, but further investigation is necessary. So the liposomal irinotecan is a topoisomerase inhibitor featuring a liposomal formulation of irinotecan, which has an advantage in enhanced tumor exposure of active metabolite, the SN38. Liposomal irinotecan plus 5-fluorouracil and leucovorin showed significant PFS and OS improvement compared with the 5-fluorouracil leucovorin for patients with gemcitabine refractory pancreatic cancer in phase 3 Napoli 1 trial. Given that the PTC also has enriched stroma similar to the pancreatic cancer, the liposomal irinotecan may be active in BTC. The NIFTY trial is an investigator-initiated multi-center randomized phase 2b study comparing the liposomal irinotecan plus 5-fluorouracil leucovorin versus 5-fluorouracil leucovorin as a second-line therapy after progression on the first-line GemCis in patients with metastatic biliary tract cancer. And the study was designed and initiated before the presentation of the result of the ABC06 trial. As you can see in this slide, the study design, They included patients with metastatic BTC, histologically or cytologically confirmed, at least one measurable lesion and radiological progression on prior first line, no prior second line chemotherapy, excellent performance status 0 to 1 with adequate organ functions. They stratified patients based on the tumor site and the prior curative intent surgery and the participating center. They randomized patient to either the compo or the 5-fluoride uracil, and the primary endpoint is a blinded independent central review, PFS, and the secondary endpoint is investigator PFS, OS, overall response rate, safety profile, and quality of life. So when we look at the baseline characteristics, it was well balanced, and the median age was around 64, excellent performance status, and then the tumor site 39% intrahepatic, 25% extrahepatic, 35% gallbladder disease, all metastatic patients, and the median of first-line GEM-CES was either less than 5.1 or more than 5.1 months. And then around 30 to 33%, they had prior curative intent surgery. When we look at the primary endpoint, the median follow-up period is 11.8 months, and the median PFS is 7.1 in the combo versus 1.8 in the 5-fluoride uracil, with a hazard ratio of 0.56. When we look at the secondary endpoint, PFS, as you can see here, the median PFS is 3.9 versus 1.6 with hazard ratio of 0.48, and the 6 months PFS rate is 30 versus 11.6. When we look at the overall survival, median OS is 8.6 versus 5.5 with hazard ratio of 0.68. 6 months OS is 60 versus 45. 1 year is 35 versus 22. When we look at the subgroup analysis, it was more benefit in the liposomal irinotecan plus 5-FU compared to the 5-FU alone. And then when we look at the overall response rate by the blind and independent central review is 11.8 versus 5.8, the objective response, and the investigator review is 19.3 versus 2.3. When we look at the waterfall graph, as you can see, the blue is the combination and the yellow is the single agent. And you can see here the maximum changes in the tumor size. The adverse events occurring in more than 10% of the patients, and the most common side effect is neutropenia and fatigue, and of course it's more in the combination arm. Patient reported quality of life. According to this graph, as you can see, it was not clinically, there was no clinical significance, and it was almost similar. When we look at the post-study treatment, after the trial, a majority of patients when progressed received cis or oxali plus 5-fluoride uracil, and the second most common is single agent 5-fluoride uracil, and then pembrolizumab. And the conclusion from the trial, the liposomal irinotecan plus 5-FU and leucovorin significantly improved PFS, assessed by BICR and investigator, OS and investigators assessed overall response rate in patients with metastatic BTC after progression on GEM-CES. PFS and OS benefits were consistent across subgroups, and the adverse events were well manageable. And given that the study was conducted in Korea only, global generalization of the data may be limited. However, this study is appropriately powered to compare two treatment groups and designed for a meticulous tumor response evaluation. NAB irinotecan plus 5-fluoride leucovorin should be considered as one of the standard treatment for patients with advanced BTC who failed on GEM-CES. And thank you.
Thank you, Dr. Samah, for your nice presentation and sticking to time. Now, Dr. Iman Bukhari, our panelist, she's head of quality management and consultant palliative medicine at Prince Sultan Military Medical City, will present the next speaker.
Assalamu alaikum. The next speaker will be Dr. Ashwaq Al-Olayan. Dr. Ashwaq Al-Olayan, CH, is the head of Oncology department in King Abdulaziz Medical City, and Also, Mina, director in the same institution. Dr. Ashwag, she will present the Anchor CRC study. So welcome, Dr. Ashwag.
It's working. Thank you very much, Doctora, and thank you for that, all the chairperson. And many thanks for my friend Mervet and Abdelaziz, and also Dr. Assam for the great organization. So my task to talk about this abstract, which is a single arm, phase 2, about triplet treatment for a patient with PRAF mutation colorectal cancer. So we'll start with the introduction that we know that PRAF is considered between 10 to 15% of all metastatic colorectal cancer. And with all the good therapy, the median survival for these patients is reaching 14 months with the best maximum therapy, and progression-free survival only 8 months. So the recommendation as of now is triplet chemotherapy with anti-VEGF for these patients. And we know the result from the FOLFOXIRI and Avastin that it increased the overall response rate up to 51% and also improved on the overall survival, reaching 16.8 and median progression-free survival to 8.3 months. But we know that if we inhibit only the PRAF, we have a cascade of pathways, so we might reactivate the EGFR, so inhibiting one single point on this pathway will not be enough. That's why adding 2 inhibitors, the MEK and anti-EGFR and the PRAF inhibitors, will probably make the trick. Okay, so this is the trial make them 2 phases or stages. Stage 1, they get 40 patients. Stage 2, 50 patients. They give them the triplet therapy, encorafenib, biminitinib, and cetuximab, and the total was 95 patients. 35% of the patients continue on or ongoing therapy. So the primary endpoint was overall response rate. Secondary endpoint was progression-free survival, overall survival, safety, and quality of life. So if you look at the basic characteristic of the patient, definitely all of them were stage 4 PRAF, 50% were female. And if you look carefully at the patient of age above 75, around 12%, which is very important. Performance status 0 to 1, and the tumor location 60% were in the right side and 40% on the left side. Number of metastatic more than 2 sites of mets was around 75%, which is really significant. And there is diversity on the site and location of metastatic. And if you look at, there's an 18 patient have prior systemic therapy. The systemic therapy were on the more of adjuvant and a neoadjuvant, because this is meant to be first-line therapy for PRAF patients. So the primary endpoint, the overall survival was 47%, no complete response, partial response was on 47%, stable disease on 40%, progression in 5.4%. And if you look at the waterfall, and if you look at the red line, only few of the patients have progression. Most of the patients have partial response. And if you look here, there is no significant on the subgroup analysis in terms of overall response rate. The only 2 points that catch my eyes, which is the level of CA99, when it is low, they have better overall response rate, which is something that probably I cannot explain it, but also the patient with having more metastatic disease, they have also better response rate. So the progression-free survival for these patients was around 6 months. And most of the patients received subsequent therapy, mostly oxaliplatin. Some of the patients received triplet treatment and also immunotherapy, and only 1.2% was on carry on the same triplet therapy. In terms of subsequent, patient did not receive subsequent therapy. 18% unknown death and 14% and 2.1 withdrew from the trial. So if you look at the adverse effect, the serious adverse effect happened in 51%, and The adverse effect lead to dose reduction was as high as 75%, and to stop the whole medication was 25%, and death was in 3.2%. If you look at the toxicity or any grade, the number look higher, but if you look at the grade 3, it was between 8, the highest was 9.5%, mostly GI and skin toxicity, and this is expected with these medication. If you look at the side effect, regardless to the treatment, intestinal obstruction, it's happened, and was wondering how they grade the intestinal obstruction, renal impairment, and also GI toxicity. Here, there is no change on the patient reported outcome by using 2 scale. It was tolerable for the patient. And at the conclusion, this is the only largest trial using a PRAF inhibitor in the first line PRAF mutant patient. And we look at the median age, there is a high proportion of the patient have they were elderly, more than 75, these kind of patient that we consider not to treat, but fortunately they get on the trial, and most of the patient at diagnosis, they have a good performance status, and 75% they have more than one side of metastatic, and 50% with peritoneal disease, which is even difficult to treat. So the trial met the primary endpoint, which is overall response rate, which was almost 50%. Median follow-up was 14 months, and overall survival was 17.2 months, and that be comparable with the triplet chemotherapy and treatment of PRAF inhibitors. The toxicity, when they look at the Beacon trial, it was very much close. So there is no toxicity, they were different. So that trial encouraged the phase 3 trial, the Breakwater, which is again, same concept with some twist. They will do 3 arms. Arm A, it's only encorafenib plus cetuximab. Arm B, encorafenib and cetuximab plus chemotherapy, whether oxaliplatin or irinotecan-based. And the third line will be chemotherapy plus minus anti-VEGF. So by this, I'll conclude. Thank you.
Thank you, Dr. Ashwaq, for your nice presentation, sticking to time. Dr. Huda Mukhtar, who is a consultant medical oncologist at Prince Sultan Military Medical City, will present next speaker.
Now we will go to Dr. Sylvie Lorenzo. Her topics will be abstract discussion, what is practice changing on. She is at Department of Hematology and Oncology of the Technical University of Munich, Germany. Dr. Sylvie, please go on.
Yes, thank you very much for this nice introduction. Many greetings to Riyadh. I was there. I had the chance just before COVID, and I really enjoyed it there, specifically your hospitality. So I really want to thank Dr. Mervat and all the scientific committee to give me now the chance to discuss 4 out of 5 just presented abstracts. I decided to discuss Checkmate 577, 811, NIFTY, and Anchor trial. Sorry for Dr. Kanan for now not including the deeper trial, but your presentation was just great, and I think you discussed it well already, and maybe we have the chance to go deeper into the deeper trial than later in the question-answer session. So now I will start anatomically with my favorite disease, with esophageal cancer, and I want to start with the Checkmate 577 trial. Here are my disclosures. And I just want to summarize briefly what is new in 2020-21. We learned that checkpoint inhibition alone is active. And specifically, it's active with nivolumab in the adjuvant setting, according to the results of the Checkmate 577 trial. This included both histologies, squamous and adenocarcinoma. And we also learned that systemic first-line therapy benefits from the addition of IO therapy.
We learned it for the Checkmate 648 trial, which is only in squamous cell carcinoma, a first-line trial, showing that the addition of nivolumab to chemotherapy, as well as only immunotherapy with nivo-ipi, improved survival in this really difficult to treat patient population. We learned also that the addition of pembrolizumab in combination with chemotherapy improved survival in both squamous and adenocarcinoma, but this is limited, at least by the EMA, to a CPS score of higher than 10. It's not limited with the FDA approval. And what we also learned for the adenocarcinoma is that patients who receive nivolumab in combination with chemotherapy and have a CPS score of 5 and higher have an improvement in overall survival by 3.3 months with a hazard ratio of 0.7. We just heard less than 1 week ago by the ESMO, the update with another 12-month follow-up, now 24-month follow-up in total. These results supported the primary results from the Checkmate 649 trial. And what we also learned 1 week ago is that only chemotherapy, and this is different to squamous cell carcinoma, with nivo-ipi, with the dosage nivo-1 and ipi-3, so the more toxic regimen, is not as efficacious as chemo alone. So in adenocarcinoma, different to squamous cell carcinoma, giving immunotherapy alone is not equally affected to chemotherapy alone. This is just to summarize. I just want to briefly give an overview about prognosis. You know all that patients with esophageal cancer has a very poor prognosis. Only 15% of Europeans are long-term survivors, and only 20% of patients with adenocarcinoma. We all know there's a global difference in the incidence of adeno and squamous cell carcinoma, with a peak in the Asian countries compared to non-Asian countries with regard to squamous cell, and adenocarcinoma is more prevalent in the Western Hemisphere. And this is really important, specifically if we look on the trials which are coming now more and more from China, from Asia, from Korea. And this really makes a difference in our results, and we have to keep this in mind. Here you see again, and this was shown by Jelena Janjiglian just a few days ago, that there is a distinct biology of squamous cell carcinoma in East and West, and we really have to differentiate between studies from East or West, and also the subgroups when we discuss the trial results. Of course, as you all know, the risk factors are also different. Squamous cell carcinoma basically caused by toxic agents like smoking or alcohol, whereas adenocarcinoma is more caused by adipositas and reflux disease. Unfortunately, squamous cell carcinoma is decreasing, whereas adenocarcinoma is nowadays the fastest growing incidence worldwide. And what is really interesting is this analysis by the Cancer Genome Atlas, showing that from the molecular pathological point of view, the squamous cell carcinomas resemble more or less the head and neck tumors, whereas adenocarcinomas are more behaving like gastric cancer. And I think this is also the reason why squamous cell carcinoma seems to be more sensitive to immunotherapy. Well, this is a nice review published by Lizzie Smith from Cambridge, looking at all the different targets which are nowadays under evaluation in esophageal-gastric cancer. And now, of course, I want to specifically highlight the news with immunotherapy. What kind of biomarkers do we have in gastroesophageal cancer? And of course, we have the HER2 amplification, overexpression. We should all test for MSI and EBV, and now the CPS score is becoming more and more relevant, specifically with the positive CHMP vote by the EMA just 5 days ago now, giving us the opportunity to give nivolumab in combination with chemotherapy, also in adenocarcinomas of the stomach with a CPS score of 5 and higher. You all know the slide by the Cancer Genome Atlas showing that their gastric cancer can be distinguished in 4 different molecular subtypes. These are, of course, the subtypes which the highest immunogenic potential, whereas the chromosomal unstable type is usually tumors at the G junction, and these tumors often harbor a HER2 overexpression. We know that pembrolizumab is a tumor agnostic agent specifically for MSI high and TMB high. That's why we all should test upfront in the metastatic setting for MSI high and TMB. And although it's unfortunately not approved in Europe, but it's approved by the FDA, we ask the insurance companies to cover for the cost for immunocheckpoint therapy in the specific patient population. But we all know MSI high patients are only in the range of 3%. And of course, regarding TMB, we have to discover a cutoff of 10 and more mutations by megabyte. So this is an overview about DIO trials with positive data in gastroesophageal cancer. You see I divided this slide in squamous versus adenocarcinoma, and it's also subdivided by curative intent, mostly, of course, first-line therapy, but there are also some positive trials in the second-line setting. So now I really want to focus now on the 577 trial. And therefore, we have to understand what is our standard treatment for locally advanced esophageal cancer. And here you see the ESMO guidelines. You see for squamous cell carcinoma, as well as for adenocarcinomas, a neoadjuvant radiochemotherapy is recommended. However, for the adenocarcinoma, we have two different approaches. We can treat them by perioperative chemotherapy, or we can treat them with neoadjuvant chemoradiation. For squamous cell carcinoma, the neoadjuvant chemoradiotherapy is, of course, standard of care. So we have kind of a fight between FLOT and CROSS, or between oncologists and radiotherapists. I don't know how it's your country, but in Europe, this is under investigation, and it's a big discussion who will be the winner, the perioperative improved treatment with FLOT or neoadjuvant radiochemotherapy according to the CROSS regimen. Here again, you see how FLOT improved median overall survival and 5-year overall survival. And this is clearly why we use the FLOT regimen, and it has never been compared directly with radiotherapy. So we have to wait for the bigger trials, which are at the moment recruiting. What is the problem when patients do not receive complete pathologic remission? And these are about 50%. We have high complete pathologic remissions rate with neoadjuvant radiochemotherapy, at least in squamous cell carcinoma, which is a tumor more radiosensitive. However, about 50%, and this you see here, have a really poor outcome. And for these patients, the 577 trial was defined. And here you see again the trial design, Nivo versus placebo, primary endpoint, disease-free survival. You see clearly a difference between inclusion of squamous and adenocarcinomas, with more than 70% of adenocarcinoma patients, although the 30% of squamous cell carcinoma patients responded very well. The treatment was feasible, as already said in the presentation. About 10 or 9 months of treatment could be performed. And here again, clearly the disease-free survival, which was doubled with nivolumab compared to placebo. So what about the histopathological subtype? And I think this is really interesting. PD-L1 expression matters, although interestingly, the majority of patients had a TPS, not CPS score, which was less than 1. So this were about 80%. And you see clearly that all of these patients had a good prognosis with nivolumab. But as shown in the presentation, specifically squamous cell carcinoma patients compared to the majority of adenocarcinoma patients, and patients with a CPS score which was higher than 5 had the good hazard ratios. And I think this was clearly stated in the presentation. CPS higher than 5 was 0.62 a hazard ratio compared to less than 5 with a hazard ratio of 0.89. And we still not have seen the results with regard to adenocarcinoma and a CPS score of less than 5. So we still don't know if the positive results are basically triggered by squamous cell carcinoma, and specifically in squamous cell carcinoma with a CPS score of higher than 5. However, here again, you see the summary and the statement, which is really worth reading in the New England Journal by my good friend David Ilson from Memorial Sloan Kettering. So I think, of course, we all know the approval is there for the adjuvant setting, and independent of histopathological subtype and independent of the TPS or CPS score. So all of us have to think, I think it's clear for squamous cell carcinoma, specifically for CPS more than 5, but I'm still not sure for patients with adenocarcinomas and the CPS less than 5, because for this patient population, we have really effective perioperative treatments with FLOT available. Here is the ESMO update. This was a poster just a few days ago. You see here again, hazard ratio is stable with 0.67. Distant metastasis-free, disease-free survival as another secondary endpoint is also in favor of nivolumab, and also the subgroup analysis shows again here with the longer follow-up, the results are really clear. However, again here, as mentioned before, patients with a CPS score of 5 did not really benefit from this treatment. Specifically, the good results were triggered by squamous cell carcinoma. So I want to go now to the next abstract, Keynote 811, and want to switch to HER2-positive gastric cancer. A lot was said already. We know gastric cancer, adenocarcinoma, is a very heterogeneous disease, and it makes it very difficult to differentiate between really HER2-positive and HER2-negative cancers. We know that usually HER2-positive tumors are located at the GE junction and are chromosomal unstable. And this is also a slide shown by Jelena Janjiglian, that the CIN subgroup is dominated by mutually exclusively occurring ERBB2, specifically HER2 MET, as well as FGFR2 alterations. And these alterations are also under evaluation in gastric cancer. So we had, of course, the TOGA trial, which was presented 2006 and led to the approval. However, there were so many negative trials with anti-HER2 directed therapy, basically coming from breast cancer, but you see negative results. And then the first positive trial also, which has been shown already, the MSKCC trial, the phase 2 trial adding trastuzumab and capox, the pembrolizumab. And here again, you see for HER2 positive disease, the improvement of survival, and we really see long-term survivors with the addition of trastuzumab. Here you see the results with the improvement of objective response and the disease control rate by 100% when immune checkpoint therapy was added to our standard. You see here also improvement in progression-free survival. And this led finally to the Keynote 811 trial, a trial which recruited worldwide. And this you have seen already. And I just want to highlight, of course, the main population was in the stomach, which was kind of a little bit confusing me because I did expect more in the GE junction area, and also a very high CPS score of more than 188% in the pembro arm. So of course, this is a planned interim analysis in only 264 patients, showing an improvement in objective response rate, which is a secondary endpoint, by about 23%. Of course, these are impressive data. They are not as good as we know from the single-arm phase 2 trial, where we had over 90% objective response rates. And the trial was still recruiting patients also in our center, and the FDA already approved the addition of pembrolizumab to our standard of treatment. And I was really, I did not expect the FDA to be so progressive, and the EMA, of course, did not give us the label, as we haven't seen any overall survival results yet. So I think it's an interesting trial, and because the ESMO is only a few days ago, I just want to show you in this context our own IIO trial, the INTEGA trial, which we also took part in. And this trial also evaluated the addition of immune therapy, this term with nivolumab, versus only immune therapy plus trastuzumab. And the primary endpoint was overall survival rate after 12 months. TOGA, it was 55, and this trial wanted to show in each arm an improvement up to 70 months. And this was reached with the addition of nivolumab in the chemotherapy arm. It was not reached with only immunotherapy. And as you can see here, the survival pretty equal. Progression-free survival was clearly in favor for the trastuzumab nivo FOLFOX arm. Here again, you see the summary of the overall survival rates. With regard to objective response rates, this was clearly less fortunate compared to the 811 trial. As you can see here, in the all-comer population, it was around 56%. It was 63 in the central population, but it was still less than the phase 2 trial with more than 90% from the MSKCC, and also less than 74%, which led to the approval. So it's interesting, but finally it confirms the role of immunotherapy also in HER2-positive disease. And I think this will be the new standard, and we have to wait a few more months. So now I want to switch to the treatment of cholangiocellular carcinoma. And as you know, the NIFTY trial evaluated Naliri 5FU versus 5FU alone, a regimen which was also already evaluated in pancreatic cancer in the Napoli trial and led to the approval. Our standard is still GEM-CIS, and second-line options for patients with no biomarker-indicated therapies are FOLFOX and, of course, now the NIFTY regimen. You all have seen already this slide, and also the primary outcome with the clear benefit in terms of median progression-free survival, overall survival, as well as objective response rate with 15% versus 5%. Well, we can't really compare the trials. You said already, the NIFTY trial was a clear Asian trial. The FOLFOX was basically a trial in the United Kingdom. You see here the disease was mainly intrahepatic cholangiocellular carcinoma. Of course, different patient population, which we can't really compare. And we just are happy that we have now a new treatment option in second line with this favorable, specifically in terms of toxicity, favorable regimen. So we still have to think what is the right regimen in second line. And also here, there was an interesting trial presented as ESMO. And this trial is the same regimen as in the NIFTY trial compared to cisplatin gemcitabine in the first line. So this trial was called the KNIFE trial. It was a small trial with more than 93 patients. And the primary endpoint was progression-free survival at 4 months. Interestingly, looking at the patient population, you see a clearly more patients with intrahepatic versus extrahepatic cholangiocellular carcinoma, and there were no gallbladder tumors included. The primary endpoint, progression-free survival at 4 months, which should be over 50%, was reached with 51%, and the median progression-free survival was pretty similar to overall survival. And as you can
2 minutes, please. 2 minutes.
4 minutes. what you can see here, there is a clear difference between intra and extra hepatic cholangiocellular carcinoma. And I think this is really impressive. Whereas the intrahepatic cholangiocellular carcinoma, they were pretty equal with a trend in favor for gemcisplatin. The extrahepatic cholangiocellular carcinoma, they really benefited from Naliri versus gemcisplatin. But look at the patient numbers, only 15 or 10. And here you see from the NIFTY trial, the subgroup analysis. So this is not really consistent. You see, there is no difference, but there was a clear favor for gallbladder carcinoma with Naliri 5FU. So I think this has to be looked in bigger trials if Naliri 5FU is doing better in extrahepatic cholangiocellular carcinoma. And we know that these are really two distinct diseases. So I quickly go to the ANCHOR trial, and I think I can skip, in the sake of time, many of my slides. You know already BRAF mutant colorectal cancer has a really bad prognosis. Most of the patients have the prognostic V600E mutation, which has the poorest prognosis. Of course, we have also class 3 with 594, 596, which are more behaving like RAS wild type with very good prognosis. But looking at all the other mutations, you see here BRAF mutations in yellow. These are the patients who do the very worst. Already mentioned the TRIBE1 trial establishing also in our guidelines the triplet regimen in combination with bevacizumab. However, there was a really interesting subgroup analysis by Cremolini, by Chiara, who showed that BRAF mutant tumors do not really need the triplet. It's enough if you give them FOLFOX plus beva. So you do not need to give them the triplet regimen. There was an interesting study looking at FOLFOXIRI cetuximab versus bevacizumab in first line, also presented just recently at the ASCO, showing that there is a clear benefit for FOLFOXIRI plus bev compared to cetuximab. Here you see the subgroup analysis, all in favor for bevacizumab. And although the overall survival was pretty much the same, looking at the response rates, it was in favor for bevacizumab. So then it comes the beacon generation. And we learned, as well as like in melanoma, that BRAF only therapy is not efficacious enough. We need to add an anti-EGFR antibody. And this was resulted in really better primary endpoints, comparing BRAF inhibitor chemotherapy and cetuximab compared to our standard of care. The Beacon trial, you all know, led to the approval of the doublet, basically in Europe, with the BRAF inhibitor and cetuximab, because it was clearly in favor for this combination versus chemotherapy alone. And the binimetinib doesn't really play a role, as you can see here. Triplet, doublet, basically the same survival curves. This you can see here, 9.3 months, exactly the same what you reach with the doublet. There is a subgroup with 3 metastasis locations. They might benefit more from the triplet, but anyway, it's more toxic and we only have the doublet approved. So the ANCHOR trial was nicely shown. I think it's a really interesting trial with about 90 patients in the first line. It gives us the signal that the triplet might work, at least with an objective response rate of about 50% and quite promising progression-free survival dates. However, only 40%, as shown already, reach the second line. And this is what we see always in this really poor prognostic group. And I think to give a final conclusion, we have to wait for the results of the already mentioned phase 3 breakwater trial, looking at the combination cetuximab and encorafenib in combination with chemotherapy. So I want to conclude Checkmate 5777 worldwide established nivolumab as an adjuvant treatment in previously radiochemotherapy patients who have no complete remission. And I still want to raise the question if it's the right treatment for all patients independent of the CPS score. The KEYNOTE-811 trial established pembrolizumab, at least in the US, due to an improved overall survival rate, objective response rate by 23%. However, OS and PFS data are pending. And of course, we have to wait for an approval. The NIFTY trial gives us a really good second line option in cholangiocellular carcinoma. And there are already some hints that it might also work in first line treatment compared to our recent standards, gemcitabine. And the ANCHOR trial shows encouraging disease control and also objective response rates for this really poor prognosis BRAF mutant patient population. And we all have to wait for the breakwater results and hope that we can, with these results, then treat BRAF mutant patients upfront with targeted personalized therapy. So thank you very much for your kind attention, and I'm looking forward to your Q&A session.
Thank you very much, Dr. Sylvie, for your elegant presentation and comprehensive one. Now we'll go for abstract discussion session. I will ask all the panelists and the presenters to be available for discussion. I will start with Dr. Algarni presentation, the keynote, the Checkmate 577. As Dr. Sylvie has presented, many medical oncologists do not agree that the chemoradiotherapy is the standard. Many of us, myself, use FLOT, and we don't use chemoradiation. So it is difficult to say that it is a practice changing. The comment of Dr. Algarni, Sylvie, Dr. Ashar, and the other panelists. So Dr. Garni.
Thank you, Prof. Majdi. So, you know, it's always a discussion in the tumor board when you have patients with especially gastroesophageal junction tumor. Some people are still advocating for the perioperative chemotherapy, others advocating for neoadjuvant chemoradiation. But I think in this study, it's a study-specific population, which is the population who receive chemoradiation. And it's also highlighted that patients with squamous cell carcinoma also, as we already know from metastatic setting, this is also confirmed in the adjuvant setting, they are deriving benefit from immune checkpoint inhibitor. So I think it's depends on what practice you adapt, whether you start with perioperative chemotherapy or concurrent chemoradiation followed by surgery, then adjuvant treatment. I think this has also to do with the compliance of the patient, because you know you are talking about almost 1 year treatment, the cost of the treatment, if this can be afforded. So I don't think we can make a one general statement that apply to all people, but I think it's one of the standard for someone who received concurrent chemoradiation followed by surgery. I believe adjuvant nivolumab is established new standard of care for this population.
Dr. Sylvie.
Well, I think this was a really clear conclusion, and I fully agree with you. It's a new standard for squamous cell carcinoma, and because the prognosis is so bad in this population, I would give it to every squamous cell carcinoma, which has not a complete remission, of course, but independent of the CPS score. And I fully agree for adenocarcinoma. Looking, the hazard ratio was 0.87. And and if the patient has a CPS score then less than 5, we do not know the subgroup results. And I'm not sure if this is better than our FLOT regimen. So we have, as long as we do not know if radiochemotherapy or perioperative chemotherapy is better, we also do not know if the addition of adjuvant immunotherapy can finally mind this gap. So I would stick to our standard perioperative treatment. And there are also trials with addition of immune checkpoint therapy to the neoadjuvant or perioperative chemotherapy, like the Matterhorn trial with durvalumab, which just started recruiting, or our Dante trial showing really high pathologic complete response rates. So I think this is more the way we should go for the G-junction tumors.
Thank you. I agree for the squamous myself, but for the adeno, I'm still hesitant to use the chemoradiation for it. Dr. Sharm, please.
Yeah, thank you so much, Dr. Qandil. Let me ask actually Dr. Mohammed Al-Qani. Dr. Mohammed, do you think disease-free survival, it is a surrogate marker for overall survival in esophageal cancer?
So I think this is one of the points that has been raised when this data initially presented in the ESMO 2020. We know that disease-free survival has been established or as a surrogate for patients with colorectal cancer in the adjuvant setting. But for the esophageal and gastroesophageal gastric tumor, I think the disease-free survival, this is one of the study that has established this or make this point as the primary endpoint of the study. So I cannot say it has been established in gastroesophageal or in a gastric tumor, although the previous 3 studies, if you look to the CROSS study or the MAGIC or FLOT study, they identify the overall survival as the primary endpoint of that study. How have this been said? I think we have a population who are having bad disease, bad prognosis, limited option of therapy, especially if they recur. And I think the way to go is to address the therapy at earlier line in the resectable stage or in the perioperative stage rather than metastatic setting.
In spite of there is no overall survival benefits.
So the study was not looking for the overall survival. They looked for the disease-free survival with all the points that I already comment on regarding the choosing of the disease-free survival in this setting.
Fair enough. Thank you.
Thank you, Dr. Garni. Thank you, Dr. Sadvi. For the keynote 811, Dr. Walid, are you with us?
Yes. Yes, Prof.
I was astonished when the FDA approved Pembro on the response rate. And if you look for the duration of response, 1 month difference. What's your comment? Do you think that the keynote 811 is a practice changing on the response only? Dr. Sylvie, Dr. Sharm, everybody.
Yeah. First, thank you, Prof. Majdi. I think, this is a type of patients in gastric cancers, as Dr. Mohammed has mentioned, that patients, even we are looking with a response rate with those immunotherapy, adding immunotherapy 22%. And we know there is no magic difference. But when you are looking to the patients with in the arm of is getting immunotherapy and combinations, there is really a deeper and sustainable response. I think that waiting the results of as all immunotherapy trials, I think the overall survival and seems there is and progression-free survival. I think this is the one of the unmet need to be in those patients, especially gastric cancer. So I think that is a practice change. I don't know, Sylvie and Dr. Sharm.
So let me ask you, Dr. Walid, now, if there is no overall survival data and there is no progression-free survival data, are you going to use this regimens as standard of care?
I think, Prof.
The FDA approve these regimens, and I know some hospitals they start the therapy with this not triplet, quadruplet. So the question now, if we have no overall survival and no progression-free survival and only overall response rate, which is, by the way, 75 compared to 55. So do you think this
55, yes.
going to approve this, Dr. Walid, in your hospital?
In our hospital is not yet, but you know, Prof. Is already FDA approval. I think if somebody is using it is really, I think we need to wait for progression-free survival and overall survival, but already the FDA is approved. And in those, he need, I think, a tumor board, and it's really hard questions. But actually, there is evidence for that. FDA is approved, but still, I think, depend on availability of the medications and the cost.
Just to add, we do not use it at the moment because of all the points you raised. We do not have the final survival results, and it's just an improvement of the secondary endpoint objective response rate. We do not get it reimbursed at the moment, so we are really reluctant, and we would wait to see more data with a longer follow-up. And of course, I think it might be the future to add also in the HER2 positive disease immune checkpoint inhibition. But I think we should be cautious at the moment and wait for the longer follow-up results and the survival data.
Thank you, Dr. Sylvie. Thank you, Dr. Sharm. I don't know Dr. Omar Shar is there or not. I will ask about the liposomal irinotecan trial for biliary cancer. Dr. Samah is they have compared to non-standard second line. We may consider that FOLFOX is the second line, and they have compared irinotecan, the liposomal irinotecan, with 5-FU regimen, while the FOLFOX they supposed to be the standard one. We don't know which to use, cross comparison to say 8 months or 6 months survival. We don't know which. What's all of you comment, Dr. Kanaan, Dr. Sharm, Dr. Sylvie?
So, you know, for the NIFTY trial, when they actually started the trial, the data from the ABC06 was not actually published yet. So when they started the NIFTY, they didn't, or FOLFOX was not yet the standard of care. You know, the beauty about the combination in the NIFTY is that it doesn't have the overlapping toxicity between what we see in the oxaliplatin and cisplatin. And I think the results from the NIFTY are meaningful enough to consider the combination as an option for selected patients, although we need more confirmation in a larger randomized clinical trials.
I fully agree. It's an Asian study, only Asian study. We have not the results in a Western population, except the KNIFE trial, which I showed you now in first line, also a very small trial, which gives us the hint that it's at least not inferior to our standard at the moment, with a good tolerability. So I think, as you said, for selected patients who might have toxicities, who do not accept a platinum-based therapy due to neurotoxicity, etc., I think it's a really elegant regimen which works specifically in extrahepatic cancer.
Yes, I think especially the trend now for finding targets for targeted therapy in cancer with long survival. I think these targets and even the therapy are still not available in many countries. So I think finding other chemo regimen will be useful. What's your comment, Dr. Sharm, Dr. Ashwaq?
Totally agree with you, Dr. Majdi.
There is no addition, Dr. Prof. Qandil.
Thank you. For the folfoxiri cetuximab trial versus folfoxiri bevacizumab. So, Dr. Kanaan, which type of patients do you think are best for this regimen, and which one you will use?
So if I understand the question correctly, Prof. Qandil, is which patients should I choose for this regimen? Is that your question?
Yes.
Good question. I think this regimen is not for everyone. I think we should carefully select patients. I think depth of response and early tumor shrinkage are good markers for certain subpopulation of patients. And I think the population of interest here are ones who we're trying to actually get for metastatectomy or early tumor shrinkage, so we can actually get them for some form of radical resection. So I definitely would not use it for everyone. I think we need to still consider that patients who they chose, most of them or more than 90% of them actually had a performance status of 0. And they did achieve an excellent early tumor shrinkage and depth of response when we compare cetuximab against bevacizumab, specifically in the left-sided tumors. However, again, this is still not a non-toxic regimen. I think it still has its toxicities, and I think we should choose it for, again, patients who were trying to get to achieve radical metastatectomies or radical resections.
Dr. Huda, what's your comment? Dr. Huda?
She's with us.
Yes, doctor. Yes, Prof. I totally agree with Dr. Kanaan. That is, we use it in highly selected patient. The patient we are going to be mostly radically treated, excellent performance status, because still it is a toxic regimen.
Thank you, Dr. Huda. Regarding the anchor study, the progression-free survival, or the we expected to be better in the first line, but it was more or less similar to second line. I think alone without chemotherapy, it will be hard to use it in the first line. What do you think, Dr. Sylvie?
Yes, I fully agree. We are all a little bit disappointed. And I think you are absolutely right when you say we need to have chemotherapy upfront, maybe in combination now with targeted agents, as the breakwater trial is evaluating. So for the moment, I would stick to our standard. According to the meta-analysis by Chiara Cremolini, I would use a doublet in combination with bevacizumab, FOLFOX usually, and then go for the combination of cetuximab and encorafenib, and as we learned and as it is approved, and wait for the breakwater results. Until now, I think it's not changing our daily practice.
Thank you, Dr. Sylvie. What's your comment, Dr.
Regarding the uses of chemotherapy first line on a patient with BRAF mutant with a combination of targeted therapy, I think that probably for the time being, that's the best option. And we cannot make any conclusion. Still phase 2 trial, the number of patients is very small. So probably after the phase 3 trial, probably our judgment will be clear. So with which will be the first choice of treatment. So up to now, most of our patients, we will consider probably triplet if they're fit with targeted therapy.
Thank you, Dr. Ashwaq. I would like to thank our panelists, our presenters, our dear colleagues for their elegant presentation and fruitful discussion. We will conclude this session, and I think we'll go for a satellite symposium for the next session. Thank you.
We will move.
Thank you.
Thank you. Okay, Assalamu alaikum. I think we're late by 15 minutes. So I'll present our next speaker. It's our star and our chairman of this meeting, Dr. Mirfat. She's gonna present the higher level of evidence of use rituximab in a patient with metastatic colorectal cancer. So Mirfat, you have 20 minutes, even if you're the chairman.
Thank you very much, Dr. Ashwaq, for introducing me, and it's always my pleasure to be my chair. And I would like to thank Merck for participating on this meeting and give me the opportunity to present their slide symposium as well. So I will give a very nice talk. Actually, they assigned me for a nice talk about the high level of evidence-based choices with rituximab treating RAS wild patients. And we all know after a very long period of using rituximab for the patient with colorectal, how it works for our patients. And definitely we know that we do have the rituximab for the upfront patients, and this is based on biology and histology, chemo backbone. And after giving the patient between 8 to 12 cycles, usually we are maintaining, and I think this is established therapy now, so the patient needs to have a maintenance therapy. And then you will consider if the patient have maintenance therapy, so possibility of going for the third line and re-challenge as well. And this is depending on the patient condition, and we'll come to this in a second. We have to know that the point or the theory regarding the maintenance therapy, it's an old theory, and we do have established this theory initially from the breast cancer. And we know all when we treated the breast cancer patients, we have to give them trastuzumab, and this is until this progression. And of course, the rituximab and lymphoma, it was a breakthrough and still a breakthrough. And both medications were changing the history of the breast cancer and lymphoma. And from this came the point that why we are giving the patient maintenance therapy. The main issue that it's like the inhibiting the tumor cells, and so you are maintaining the response for these patients. And this is proven the concept that the cell cycle arrest, induction of apoptosis, and the EDCC. So do we have a preference regarding the cetuximab as a chemotherapy? If we look at this data, we'll find that the cetuximab, you can use it in FOLFOX relevant, even for FOLFOX 6, 7, or even modified. And you can, in every regimen of them, based on the oxaliplatin dose. And of course, FOLFIRI as well. And I think we had a great talk with Dr. Kanayan regarding the FOLFOXIRI. And we know that the triplet regimen plus cetuximab is one of the considered regimens for specifically for site reduction. And we know that how this regimen, and we need to be selective when you're choosing our patients. So we do have, this is what we have regarding the chemotherapy. We just only have irinotecan-based regimen, oxaliplatin, and of course the triplet therapy. And then the meantime, do we need to give all the patients all the treatment time? No. This is the concept of the chemo holiday. And I think we have to always to admit that we need to give the patient the break. And myself, and I believe that a lot of my colleagues doing the patient break, like holiday. And this study, which is the CONE study, the phase 3, intermittent versus continuous FOLFOX Zelox. And it was, you can see that the patient relevant of the condition, you can see that you cannot separate the two curves. And both curves, it's not statistically significant regarding the continuous and the intermittent. And even we are giving them toxicity more than continuing the treatment. And if we look at here, we found that Scott Berry from Toronto, he published a meta-analysis, and this is since 2015. And you can see almost 10 trials. And he looked at those patients as an overall survival was intermittent versus continuous. And you cannot see that. Definitely the patient who's continuous treatment, they have some favor, but however, we found that those patients, there was no overall survival benefit for them, and it was affecting their quality of life. And this is proven the concept that meta-analysis, it was concluded that intermittent therapy or stopping the treatment for the patient does not have detrimental impact on the overall survival. However, we have to look at the point of the tolerability and the quality of life, which is really important, and it's really matter for such patients. And this is proven the concept that do we need to give this patient a chemotherapy long period, but this is affecting their outcome. So one of the questions which was highlighted in ASCO GI last year, and it was mainly that for the patient maintenance cetuximab versus observational. And this was done, it's a French study, and it was the Unicancer study. And you can see that those patients, they were receiving FOLFIRI cetuximab as upfront, and it was around this patient about 120 patients, and you can see that the cetuximab in between, and then if this progression, we will go for the chemotherapy alone. Again, sorry. And the study, the primary endpoint was the 6 months progression-free survival, and you can see that the cetuximab maintenance for around 60 patients, it was 34.3 versus observation, which is 6.9. And you can see clearly visually, but the curve has a significance regarding the patient who's receiving cetuximab versus supportive care observation. And you can see that 5.3 versus 2. And this again proven the concept that those patients with maintenance therapy, they have a better outcome comparable with the patient just only observation. And in the meantime, we are not affecting the quality of life as before we had the oxaliplatin-based regimen as a continuous therapy. And you can see that most of the patients, they were having toxicity, they have Peripheral neuropathy, however, in the Stuxmab, the quality of life and safety, it was reached. And in the meantime, the median PFS, we can see 5.3 versus 2 months. And here, the 6 months progression-free survival, almost 4 times or 5 times even more. So if the Stuxmab monotherapy maintenance is inferior to the, because it's always, we are an oncologist and always we look at the point that maybe if we are giving the patient more chemotherapy, they have a better survival and better control. If we look at the macro study, you will find that the study of Stuxmab maintenance therapy for the patient comparable to the patient who's receiving Stuxmab modified FOLFOX, and then treatment until progression, you can see that those patients, there was no difference between them statistically. However, when we look at this curve, we will find this table, we can see that those patients, they have a toxicity higher and the peripheral neuropathy, and even those patients, the tolerability was less. Again, proving the concept. The results of the phase 2 exploratory trial, non-inferiority for the maintenance therapy for this patient, that's a Stuxmab, it can be non-inferior to the modified FOLFOX plus Stuxmab and can have a better outcome for this patient. So how if we are switching the gear between the Stuxmab and panitumab, we have the Valentino study, and it's a phase 2 study, and you can see that it's almost 200 patients, and FOLFOX for panitumab with panitumab chemotherapy, and then they maintain with panitumab versus 5-fluorouracil. The study was examining the arm regarding the maintenance. If 5-fluorouracil with panitumab is the same like panitumab alone, and you can see that the 5-fluorouracil panitumab is superior to panitumab alone, and even you can see that the hazard ratio 1.55. This means that those patients, if you are going for maintenance with panitumab, you need to go for 5-fluorouracil. Panitumab alone does not have the same efficacy like panitumab with 5-flu. And this was another study, which is the Macbeth. Macbeth, it's a Stuxmab FOLFOXIRI versus Stuxmab FOLFOXIRI 6 cycles, and you can see that Stuxmab comparable to bevacizumab as a maintenance therapy. There is difference between the two arms, and you can see that almost 100 patients. And there was no difference between the study regarding the maintenance between the Stuxmab and bevacizumab. However, this study gave a signal that the response rate and the rate of the resectability was higher in the Stuxmab arm. And I think we had a talk about the depth of response. And the patient who's receiving Stuxmab arm, they have a better outcome regarding the resectability and the tumor control. And we know that when you are using the patient with EGFR inhibitor and giving them Stuxmab, those patients, they have a better outcome regarding the tumor response. So reaching the point that we have induction therapy, irrelevant of the type of the chemotherapy, you have a maintenance for them, and are able to go for the patient. So you can go for Stuxmab every second week in the first line for this patient. Another study, which is the Banamat, was launched in June in the last ASCO. And you can see that it's 5-fluorouracil plus panitumab versus 5-fluorouracil, and it was estimating that do we need to give this patient panitumab plus 5-fluorouracil, and you can see that 5-fluorouracil as a chemotherapy alone for this patient is inferior to panitumab leucovorin, and so the biologics plus chemotherapy is superior. And you can see that the starting of the curve, there is separation, and it was significant difference. However, the overall survival doesn't met 0.32, and you can see crossing of the curve. The toxicity profile and the response rate, it was very comparable, and it was in favor for the combination versus the 5-fluorouracil. One of the main issues that do we need to do more specified tests for the patients? I think Stuxmab, this will be answered by the ERMS study, which is a phase 3 study. They will include 600 patients. The study results expected in Feb 2019, and it still we don't have the results yet. The main issue regarding this study, they are doing liquid biopsy for a patient with Stuxmab maintenance. They are trying to estimate the patient who is progressing and doing NEURAS for this patient. And I think it will be a very good element regarding the biological elements. Another study, which is the FIRE4 study, and you can see that stuximab FOLFIRI versus stuximab FOLFIRI followed by bevacizumab as a maintenance. And it was this study, it was estimating if you are giving bevacizumab FOLFOX as a second line, and comparable that we then randomize the patient to stuximab versus physician choice. And I think the study results will be in the next ASCO GI. The main point that in every element of the study, they are doing liquid biopsy, and so they are estimating the patient outcome. How about the guidelines? The guidelines, the ESMO guidelines endorsing the induction, endorsing the maintenance, and they are in favor for the treatment holiday, and you need to go, and also the reintroduction, it's all there, and you need to just only to individualize for the patient. And because most of the physicians, they are not in favor for the maintenance for the patient. However, in the ESMO, they are endorsed and they are in favor. In the meantime, the same category regarding the NC guidelines, they are endorsing the intensive first-line therapy followed by maintenance therapy and reintroduction as well. Reaching to my final slide, stuximab as a chemotherapy regimen, you can use it relevant of the chemotherapy you can give with FOLFOX, FOLFIRI, and the second element, you need to go for maintenance, you can go for stuximab single agent versus chemotherapy, and it was in favor as a maintenance therapy. And in the meantime, the reintroduction and re-challenge can be considered as well. Thank you very much for your attention.
Thank you, Mervat. Excellent timing. So I have a question. At what point you would consider starting maintenance therapy? When the patient have stable disease, when the patient have partial response, or you will give to a certain number of cycle, or if the patient start to develop toxicity from the backbone chemotherapy, at what point you would consider? I know it's vary from each clinical trial, but as an oncologist, what you will do?
Thank you very much, Dr. Ashwa. This is very important questions because it was elaborated by the studies as well. And in the meantime, as you pointed out, the number of cycles for the patient between 8 to 12 cycles, because in other studies when they are giving continuous treatment, it was affecting the patient toxicity and doesn't affect the response rate or PFS at all. So the guidelines and even the expert made their decision that the patient maximum for them 12 cycles, reaching to the partial response or the stable disease for the patient, and you can go for maintenance. If this patient during the maintenance, they are going, and again, it depending on the patient situation and the tumor burden, what is left, and if you are switching between one line to the other, so it's not fixed idea, but definitely the patient core is the main. I always put in my consideration that I not exceed 12 cycles regarding oxaliplatin because most of the patient, they will not benefit more. And if there is a high tumor burden, I reach to the maximum for this patient. I can switch to irinotecan, so I can give the other option for the patient before going for maintenance. Because the maintenance, you are decreasing the tumor, the chemotherapy intensity. And so I wanted to leave them as much as they can and they can tolerate it. This is the main concept. But as you pointed out, we don't have a specific trial who's answering this question. It's mainly depending on the physician discussion and again, patient comorbidities, age. And when I'm feeling that this patient, it's quite enough and we can go for maintenance, we have to go slowly on this patient. And in rapidly progressive disease or high tumor burden, I will go for switching before going to maintenance.
Thank you. Question?
You are my chair in the second session.
So I'll prepare from now. So thank you, Dr. Mervat. It's amazing as usual. So my question is, what's your recommendations about the maintenance therapy with targeted therapy alone? Either anti-EGFR or anti-vascular endothelial growth factors?
Well, this is important, definitely, Dr. Sharm, because I think we, as oncologists, we always in favor to go for the maintenance with chemotherapy. But when we pointed out the study for the stuximab comparable to the chemotherapy, there was no difference and non-inferior. I think it's our perception that if you are giving the patient with chemotherapy, it may, in the chemotherapy, in the panitumab +5, it was definite answer that chemotherapy alone is not enough for the patients, but you can give chemotherapy plus panitumab, if you are choosing panitumab. If you go for cetuximab, you have two choices. It can be with 5-fluorouracil. There is small studies regarding cetuximab plus Xeloda, but we are not in favor for it because it's not consistent ideas. But sometimes you can go if the patient is from far away and it can be acceptable. But however, the cetuximab 5-fluorouracil is more acceptable as maintenance or cetuximab single agent. This is both can be.
Well, I think the trial more with cetuximab in terms of maintenance more than yeah.
Yes.
Any other further questions?
Yes, Dr. Mervet. What about chemo holiday? If you wanted to give a chemo holiday, what is timing you can enter it, and what is the duration you can expect from the start?
This is an excellent question. Again, Dr. Huda, the point of the chemo holiday, we don't have a fixed time, specifically that with the COVID even situation, we give the patient chemo holiday for the patient with a stable disease. You are following them with maintenance long time, and the patient, they just only can go for vacation or anything. They have something to do. So I allowed it for my patients for maybe 2 or 3 months, and then I wanted them back. At least for them, I can just go for the tumor markers and lab, and I don't have to, if I do have find that the marker is going up, I jump it to the radiology, maybe this patient is in progression. So it's a flexible, and the holiday, we don't have a fixed timing for them. Regarding which patient, definitely the patient who's responding, at least the patient who's stabilizing the condition, and at least we can have that, we can following this patient. I mean, I give them holiday, but I need to just give them the message. I need to see them maybe after 3 or 4 months, and we have lab and we are in touch.
Can I add one thing? When you had a patient and you've treated them for a while, probably you will know the biology of the patient and the biology of the disease. And you see when the biology is not an aggressive disease, these patients, you will be encouraged, as Mervet mentioned, that if they are stabilizing disease or low burden of disease, to give them holiday, because they will be in chemo forever.
Yes.
So thank you, dear Mervet. So
you.
my next chairman, my dearest friend, Abdullah.
With the same speakers. طيب, السلام عليكم جميعا. Thank you so much, Survey, for the nice contribution today. A matter of fact, we have a distinguished speaker that, beyond any introductions, Professor Mervet. She's going to speak about second line, beyond second line therapy in metastatic colorectal cancer. So the floor is yours.
Thank you. Thank you very much, Dr. Sharm, for introducing me. It's always my pleasure. And can I have photos? And thank you, Servier, for contributing. And thank you. They assigned me again for a very nice talk, which is the management of metastatic colorectal cancer beyond second line. We know that we are treating colorectal cancer now with different phases, because the colorectal cancer metastatic patient, they are moved from the median OS 6 months reaching to 30 months. And this doesn't came from blind spot. This is came mainly that we are switching between the first line, second line, third line, and re-challenge as well, and doing understanding the biological markers for this patient, this changing our practice, and changing the number from 6 months to 30 months. And even we do have much more that was Pempro as IO therapy, and we do have the test, and we have regorafenib as TKI as well. When we look at this graph, you will find that again it's going up regarding overall survival for this patient, and the switching between one line to the other, it's the main issue. So what is the third line treatment goal? As we know, for the first line, usually we are looking for the tumor response. For the second line, we are looking for the control of the disease. For the third line, usually the main goal for us is maintaining the quality of life, extending survival, and disease control. This is because that you are aiming that to lengthen the period of the patient. You wanted to give them something that they can tolerate in their life, and also to control the disease. So the first one is regorafenib, and of course we all know that regorafenib from the correct study. The correct study it was presented by Axel Grossi since 2013, and at that time it was a hit. That it was multi-center randomized double-blind. Why it was a hit? Because we are very deficient regarding the colorectal. About we just only have the irinotecan and oxaliplatin, and so introducing another element for treatment for such patients, it was something we were looking for. The study design, it was 2-to-1 randomization. It was about 700 patients. Regorafenib, it was 160 milligram for daily for 3 weeks and 1 week off, and versus PIS supportive care. And there was no crossover allowed. The primary endpoint, it was overall survival, and the secondary endpoint, it was PFS, response rate, and DCR. And you can see that the study met the primary endpoint as superiority of regorafenib versus PIS supportive care. And even it was a decimal, it's just only 1.4. You can see that the median overall survival was 6.4 versus 5 months. And you can see even the crossing at the end, which means that there is some benefit regarding the treatment. And the hazard ratio for the patient, it was 0.77. In the PFS, it was 1.9 versus 1.7, and the hazard ratio, it was 0.49. And you can see that there was crossing of it was very near the curves to each other, and start after 2 months to little bit separate, and the patient who respond continue the response. And when we look at the correct study, we found that the toxicity profile usually starting in the first 2 months and then a little bit decline. But however, the pattern of the toxicity is known, and I think it was one of the barriers for the treatment, which is the hand-foot syndrome, the fatigue, the diarrhea. And I believe after about 7 years of using regorafenib for the patient, we know exactly what is the pattern. Most of the patient, they are coming. This is why we need to select the patient based on the performance status and the patient who can tolerate the treatment. And after 2 years of using the treatment, Becky Saab from Mayo Clinic as well, he introduced the REDOS study, which is a phase 2 study. The idea of a study that they are escalating the dose gradually for the dose for the regorafenib, and they stratified the patient to arm A and arm B, as they start first with the 80 milligram and then escalate to 120 if the patient tolerate, and if the patient didn't tolerate, they can return back to the standard dose versus the standard dose of regorafenib. And I think it was make a lot of difference that it was the first time that most of the patients, they can tolerate the treatment. And since this time, since 2018, which is presented in ESMO GI, it was that this is the way how to use the regorafenib for the patient. You can go by escalation other than giving the patient the full dose. And in the meantime, the monitoring the patient, it was one of the key issues as well. And you can see that the median 9 versus 5.9, and we have to know that dose intensity is truly important for this patient. I mean, the low dose, usually they are not responding like that. The patient who have at least reaching to 120, this was reported. However, the PFS, you can see there was a crossing, and the median 2.5 versus 2. The quality of life, you can see that the arm A, which is the arm was escalating dose, you can see that those patients, they are starting to have a better comparable. Even the two lines came together again. One of the main elements regarding the toxicity profile decreasing from the grade 3 and 4 for such patients, specifically for the hand and foot syndrome and the fatigue. So after a while, almost 2 years after regorafenib, it was launching the study of the RECORD study. It's TESS 102, and the study, it was presented by Meyer and published in New England Journal of Medicine. And the main point, the study was almost the same fashion like was done by CORRECT. It was 2-to-1 randomization. It was almost 800 patients. But however, the TESS 102 is different than the REGO, as it's a chemotherapy chemotherapy, but it's the main point that it's more specified, and even the patient with fluoropyrimidine receive treatment that they can be, because it's more potent as a molecule. The main point that the test as a regimen, it's 35 milligram per meter square, PID day 1 to day 5 and day 8. So it's almost 10 days, and then patient has to rest for 2 weeks. So the convenience of this regimen, it was one of the elements as well. The primary endpoint, it was overall survival, and the secondary, it was PFS and response rate. And again, it was the same. I have to point it out even regarding the correct study that when you are selecting the patient, you will find that for the Concord study, even they have the same data. I mean that selecting the patient criteria may affect the results. So in the Record study, you can see that the overall survival for the patient for 6 months, it's 58 versus 44. And this patient was heavily pretreated, and patient with regorafenib were allowed as well. And so, and for the 12 months, it was 27 versus 18. And you can see early separation of the curve starting from 2 months. And for the PFS, you can see that those patients have a significant difference, and again, almost overlapping between the two curves, and then starting from the 2 months of separation, and this is a patient who is responding. The main issue that we don't have a specified biomarkers to identify those patients who is responding. However, in the analysis, they try to find who is patient can be subjected or can have a good response. One of the main issues also is the time to deterioration and the performance status. This is why that when you have a patient with performance 0 to 1, and I think this is very difficult in the real life, that patient was heavily pretreated or having 2 lines or 3 lines of treatment, you can have a performance 0 to 1. So most of our patients, they can ranking 2. Other than going for 0 to 1. And here, the stratification for the patient. So they stratify the patient as a good prognostic, best prognostic, and poor prognostic. And the good prognostic, they identify them as 1 or 2 metastatic site. And the patient had progression since diagnosis of the first metastasis more than 18 months. And the best prognosis, it was 1 or 2 site metastasis. And the time to diagnosis of the first metastasis was more than 18 months. And the main element for the best prognosis, it was no liver metastasis. However, the poor prognosis, peritoneal deposit, more than 3 metastatic site, and the performance status as well. So look at the patient with good prognosis. Those patients, you can see even better of the study itself. You can see doubling regarding the 16.4 versus 8.6 for this patient. And you can see risk reduction 53%, hazard ratio of 0.47. And here for the patient, 4.4 versus 1.9 for the patient with best prognostic. Those patients, there was no liver metastasis, and this is the PFS for the ITT population, and even better regarding the hazard ratio of 0.35. So it's 65 risk reduction. And I think this is give us a signal that those patients, you can stratify them, that patient with best prognosis, so this patient, they will be responding, and so you can have a better control of the disease. When we look at the quality of life, which is totally different than what most of the assessment, which is done by other studies like Correct Study and Cosine, and even what we are seeing, because in this quality of life, they looked at the time to disease progression. They looked at the time spent to the treatment-related events. You can see here the time to disease progression, which is the REL, the TOX, which is the time to spend to the treatment adverse events, you can see here. So either for the patient with time to disease progression, you can see it's here comparable with the placebo, looks better. And the twist here, you can see that for the time without toxicity, you can see here in the test 102 arm. My point that regarding the quality of life, they measure it totally different. And I think they are looking at the disease criteria more than the patient criteria about the functionality, fatigability, all this stuff. However, when we look at test 102 as a non-hematological toxicity, you can see that most of the patients, they can have nausea, vomiting, fatigue, diarrhea, and it was all tolerable. And if you will ask me about what we are seeing in our patients, most of the patients, they just only fatigue between grade 1 and 2. The most striking one is the neutropenia. And you have to point it out that neutropenia is subclinical. No patient we had have febrile neutropenia, but the neutropenia can be noted in the blood work. So every time the patient come, what is really was good that it was found that the neutropenia grade is correlated with the patient PFS and the patient outcome. So the patient who developed neutropenia as a grade 1, B, C, D, and of course I will not go for the grade D, I will be just afraid for this patient. So the grade 1 and B and C, you can see that this is comparable to the disease sensitivity and the tumor response and the outcome of the patient. So you do have now two treatments, how to choose. You have the regorafenib, you have test 102. It's very comparable. You cannot say one treatment more than the other. So how you can choose? You choose based on the patient criteria, performance status, the tolerability, and this is you can use. But when you look at the numbers, you will find it's very comparable. And two landmark study, the correct and recourse. The regorafenib, it was the one who was before the test 102. However, some people, they are going for the rego followed by test, or people can go for test followed by rego. This is depending on the patient criteria and the physician discussion as well. Regarding the toxicity, every medication has a toxicity profile different, but we have to put in consideration that the patient with regorafenib is anti-angiogenic, so patient with thromboembolic manifestations, frail patient, they will not tolerate. However, frail, you have to consider that any of the treatment can be harmful for the patient. So the patient, the performance, it will be 2 as maximum for this patient. And for the febrile neutropenia, it was not recognized in correct, and however, it was 4 in recourse study, and you can see that the neutropenia is comparable with the outcome of the patients. The efficacy, subjectivity of the toxicity, I think this is always how to choose between medication to the other, all here in the NC guidelines. And in the meantime, you have to put in consideration the re-challenge again. So how you consider re-challenge for a patient with symptomatic aggressive disease, you need to go for the chemotherapy. However, for asymptomatic patients, tolerable for asymptomatic patient, and you can see this progression, good performance status, I think this patient, they need to go for TKI, and you can save the re-challenge for this patient. And relevant to what chemotherapy you start or biologics, you can go for the 3rd line and the 4th line for this treatment. So do we have any chance for improving our outcome? Yes. This was a study which is a combination between test 102 and bevacizumab, the task force study, and you can see that this study, it was test 102 plus 5 when we add the bevacizumab 5 milligram per kg every 2 weeks for the patient, and the study was randomized 1-to-1, and the primary endpoint was PFS, and the secondary it was OS. And you can see that most of the study, they even have 5 lines of chemotherapy for the patient, and they receive everything. What is really astonishing about the study, even with heavily pretreated population, you can see that the hazard ratio 0.45 and the P value is 0.1, and the overall survival even significant. And I think this is give us a signal that patient with a good performance status, specifically that you can see that patient more than 70, they are crossing the line. However, the patient less than 70, I think they can deserve this kind of treatment, and there was no crossing whatever. Regarding the toxicity profile, we all know the bevacizumab, however, the neutropenia was higher, and also the anemia and the proteinuria as well. as a bevacizumab combination. And again, this is the final update of the data. And you can see that still patient can continue, and even the hazard ratio even better, 0.52 for the PFS and the OS 54. And patient with performance status here, we can see that 5.7 months, and it was significant regarding the quality of life and treatment duration. My last slide, both TES-102 and regorafenib improved the overall survival and PFS and chemorefractory metastatic colorectal patient. We need to go for TES-102 for patient with maintained ECOG, and I think we had a study which is retrospective study, Japanese, which is comparing between the TES-102 and the regorafenib, and it was in favor that for patient more than 65, you need to go for the TES-102, if then and the patient with performance 2 as well, and you have to monitor your patient regarding the neutropenia, and it was very tolerable. Thank you very much for your attention.
Thank you so much, Dr. Mirfat. So do we have any questions? So let me talk to you about our experience with Regora and beyond second lines. Regora, it's a very, it was used initially before the TES-102.
Right.
However, we hardly reached to 160, and I never reached to 160.
Me too.
So I reduced it to 120, and in spite of this, it was very toxic, especially with headphone syndromes. So what's your experience with Regora and beyond second line therapy in military hospital? I think they publish your data, retrospective data about that.
Yes, we do have a good experience regarding regorafenib in our patient population, and we, as you pointed out, we had the retrospective study, and even we are using this for the patient. But again, it's depending on selecting what patient profile we have to go. So the patient has a good performances. I mean that reach PS1 and patient younger than 60, we can go for it. The main idea for using that you can use Rego followed by TES. However, now if you do have a patient with TES-102 with the data with bevacizumab, regarding the response rate, I think we have to reconsider this issue. So for our experience, we used, and we have patients with regorafenib, and we are giving, starting first with 80 milligram. I usually start the first cycle with 80 milligram, and then not weekly, to be honest, I'm not going for week. I wanted the patient to adapt to the dose and then escalate gradually. And if they are tolerating, so the maximum I reached it was 120. And it can be tolerable for most of the patient. In the meantime, patient education is truly important for them.
Excellent. So what's in your practice about TES plus bevacizumab in third line setting? Are you using this now in your
practice? I have 3 patients actually for TES-102. I selected the patient young population who they are progressing after chemotherapy, after the doublet, and I mean, yes, I mean, those are exposed to, you are reaching to the point that they are having oxaliplatin and irinotecan, and I wanted to give them TES-102 plus bevacizumab. So the key point for them, good performance status and the tolerability. So, and I reached to between stable disease, maximum for this patient, and some reduction. I don't consider it a partial response. And this is considered something for the colorectal patient.
You're completely right. So in our practice now, we use TES plus bevacizumab and beyond second line therapy. So without any further, I would like to thank you, Dr. Mirfat. Thank you, Survey, for this nice, arranging nice lectures. I think we conclude our meetings, right?
Yes.
Thank you so much.
Thank you again, Dr. Sharm, for joining, and thank you everybody for joining us from a different region. It was a beautiful meeting because of you and all our speakers and all our attendees. I would like to thank all the participating companies, all the panelists and the chair or the organizer, and I have a special thank to Event Troop for their excellent organization and their effort. Thank you very much. Have a great afternoon.